Good afternoon, everybody, and welcome to this session, or good afternoon, or good morning, I should say, wherever you are in the world looking at this session on what, why, and when in labour management. My name is Michael Robson, and I'm delighted to welcome you all. We have 5 speakers today who are giving talks as per the programme. I won't go through the titles at the moment. They'll have 20 minutes each. And then there's a small 5-minute presentation afterwards. And if possible, we will take all the questions at the end. But I understand that you've been told that you can post questions as we go along with the meeting. So I am the first speaker, and I am going to talk about prolonged labour, just looking at the programme there. And just to introduce myself, I am a consultant obstetrician at the National Maternity Hospital in Dublin, former master there. I am speaking today as somebody that does mainly obstetrics and mainly labour ward. I do also do gynecology. I write a little bit of papers, but I'm also interested in perinatal audit. In addition, I am clinical director for the national implementation of a fully integrated electronic patient record for maternity and neonatal care in Ireland, and that is a lot of what I do at the moment. Now, just share my screen, which I am struggling to find there. There you go. And birth 2020, prolonged labor. This is a quote from Galileo, and I think it's very central to what I'm going to be talking about today. You only know what you measure, and what you cannot measure must be made measurable. I think that could be applied to any organization or any facility trying to improve, to look at the care or realize what they're doing. And that statement also suggests that not only must you know what you measure, but sometimes measuring things may not be easy, and they have to be defined and collected in such a way that they make sense. But that statement is as true for any other organization as it is for birth, labor, and delivery. And we must also remember that it's not only what we want to measure and look at, but it's also what our patients, our women, want to know as well. And duration of labor is one of those things, outcomes, if you like, that not only do women want to know that, they also want to know when they go into labor. But duration of labor, once they've gone into labor, most women want to know how long it's going to be. And I don't know how many of you actually manage to measure labor or record it or look at it on a continual basis, but it's not a very easy thing to measure. But nevertheless, it's very important. I would say that it's probably difficult to exaggerate what the beneficial effects of an accurate working definition of labor on everyday practice is. And surely failure to define what this is and to collect it in a prospective manner, one of these basic parameters of clinical obstetrics, I would go along with the hypothesis that this has been a major obstacle to improving management of labor for many years. It's defined as, and so when we get on to how to define it, the definition of labor obviously is when labor starts and diagnosed, can cause problems when it's induction of labor. But certainly from my point of view and what we try and do in terms of looking at labor, we define it as the number of hours a woman spends on the delivery unit from the time of diagnosis of labor, i.e. admission to the labor ward, until her baby is born. And the reason why this definition has been chosen is that the time of admission is a maternal decision. Now, obviously, when a mother comes into the labor ward, or into the hospital to have a baby. And obviously the definition has to be changed a little bit if they're having it at home. But it is fundamentally a maternal decision. And professional responsibility begins when that woman elects to place herself in care. In addition to that, because it's an objective way, duration can be recorded accurately for purposes of comparison. And certainly when you're going to look at that information in the future, you'll be able to look at from the time that care started, labor diagnosed, and what happened as a result in terms of length of labor. And mothers themselves tend to recall duration of labor in this manner. You will note that no account for the length of labor at home has been calculated into that. And some people would therefore disagree with the definition. Indeed, a lot of what I'm going to say, many people would not agree with everything. But these are some ideas to how other people have approached the subject. The very fact that a woman comes in labor and maybe 7 centimeters is not necessarily always a reflection that she's been in labor for a long time at home, merely that the uterus has been efficient, as many women may come in after hours and hours at home and very tired as a result of it, but are only maybe 1 or 2 centimeters. But the issue of definition of duration of labor is difficult. And whenever you're defining something and looking at something, to have a methodology that can be repeated is very helpful. But it also, this definition of duration applies equally when a woman who is not in labor remains in the delivery unit for whatever reason. So hence the duration of labor in the case of a woman admitted for induction is likewise recorded as hours spent in the delivery unit, because this is the actual duration of stress to which she is exposed. And it is appropriate, I think, to talk about stress during labor and the element and the effect that they may have on women. So if we agreed on that, then we get to the issue of diagnosis of labor, probably the most important decision in obstetrics. And while obviously any duration of labor will depend on the diagnosis of labor, I think if we were all realistic about this, we're never all going to agree and use the same diagnosis of labor. That doesn't really matter so much as long in any particular delivery unit, you are consistent in making the diagnosis in the same way, that you have a guideline on what the diagnosis of labor is based. But the diagnosis must be prospective. The intention to treat is an important part at looking at any information. And if you're going to go retrospectively after a woman's delivered and say, well, it was about 7 hours ago that she started getting her pains, or she says, no, it was 24 hours, that isn't really effective. It should be a prospective decision, and in fact be a positive decision to commit a woman to delivery. By doing that and recording that decision, and it's in spontaneous labor, then you will get that cohort that you have diagnosed as spontaneous labor and be able to look at the results. I do believe the diagnosis of labor should be made by the midwife for practical reasons as much as experience reasons. I think it's an important diagnosis, and I don't think almost it should be shared out. And doctors making diagnosis of labor, I do not think personally helps to run a consistency in a labor ward if you've got about 30, 40 people making the diagnosis of labor. It's not to say doctors can't make the diagnosis of labor, but there are advantages of being one central decision maker. The history, obviously, uterine contractions, plus or minus show, plus or minus rupture of membranes. But this is where we get to the particular bit of confirmation of diagnosis of labor. And the effacement of the cervix, and I mean 100% effacement, is the important issue, irrespective of degree of dilatation. As long as the cervix is effaced and it's accompanied by the appropriate history, then I would suggest that labor is diagnosed. But as I said, the definition may change and may be used differently. The problem about diagnosing labor if the cervix is not effaced and say that it's 2 centimeters, 3 centimeters dilated, certainly in the nulliparous woman, is that when the cervix is taken up, and as it's taken up, that happens over a period of hours. So actually the dilatation is not changed, or it's not differentiated between a cervix that is started off originally as uneffaced and becomes effaced. And from a diagrammatic point of view, this is what I'm trying to say. So this cervix is not effaced or dilated. Sometimes you can get a finger in or even 2 fingers in, but a cervix does not actually begin to dilate, because it's the external os that dilates until the cervix is fully effaced. And that, in my view, provides an objective way of diagnosing labor, and one which possibly would be easier to compare. Too often, diagnosis of labor or papers that you look at in literature, when the cervix, the effacement isn't commented on at all, and the cervix is said to be 2 centimeters dilated, possibly by being able to get 2 fingers in, but the cervix not effaced. We would call that 0 centimeters. Now, having talked about the diagnosis of labor, in order to measure a length of labor, indeed, in order to measure and visualize anything that goes on in labor, you need a partogram. And I'm not going to get into the debate of the partogram. It's a very debatable, a very controversial issue at the moment. People have different opinions. But when I'm talking about a partogram, I'm talking about the graph, really. I'm also talking about the visual presentation of information, and that makes it very much easier to look at. I think I do not tend to think of a partogram as action lines or what the rate of progress should be or not be. I think that's entirely up to the individual organization to decide. But what I regard as a partogram is just a visual presentation of what's going on in labor. But you do need a partogram, I think, to begin to measure a length of labor. Now, this is the partogram that we use. As you can see, it's a yellow color. We use that for nulliparous women. We have a different color for multips without a scar, and multips with a scar, which are blue and pink, respectively. The big issue and the big discussion issue is this issue about the latent phase and active phase. And indeed, I was originally asked on this lecture to talk about protracted active phase. I don't think it's useful to take, or easy, shall I say, to take the active phase out and separate it out from the latent phase and talk about that separately. I think to a woman, labor is labor, and pre-labor is pre-labor, and active labor is maybe when progression occurs more quickly. But labor, when you ask the woman, is not defined as accurately as we depicted on this partogram. But I do think a few hints on how we can make it a little bit objective. The problem about the latent phase is we may well know when it ends at 2 or 3 centimeters, but the definition seems to be changing all the time, and that's another problem. But we have a problem of when it begins. And I would suggest that if you're going to measure labor, you need something objective. And the time that we start our partogram at 1 centimeter is when the cervix is fully effaced. So even if the cervix accepts a finger, what some others may call 1 centimeter, but it's not effaced, we might say they're in labor in certain situations, or measure the length of labor from that time if there was an induction, but we would depict it on the partogram as 0, which allows progress to be visualized graphically by the effacement of the cervix, even though in purely anatomical terms, it hasn't dilated anything. So dilatation only occurs after effacement. And we think that effacement, or I would think that effacement of the cervix is the key to the diagnosis of labor, and its graphic analysis. And that is when the partogram is started. And then after that, in terms of the length of labor, obviously the length of labor is mainly taken up by the first stage. And when the baby delivers, that is how we would measure the length of labor, not including the third phase of labor. And I would suggest, if you're going to look at the duration of labor, something which is very important to the woman, however you define it, you need an objective way of defining it, and also depicting the progress. Now, you will note that I'm not going to talk anything about how you manage labor or how you decide. I think you've got to, as a unit, decide yourself what your results. But I would argue the case for advantages of short labor. I think from a maternal point of view, it is mainly the emotional aspect of prolonged labor that's a problem. Shorter labors tend to have also more normal deliveries. But certainly the emotional aspect of labor is one of the big issues. And while a woman well prepared by good antenatal education and continuous personal attention can withstand the average, maybe a 6 hours, maybe possibly even 12 hours. But after 12 hours, there is a deterioration in most women's morale. And I'm not saying that's the same for all women. I'm just saying the vast majority. And obviously their morale in labor and how they cope with labor also depends of some kind of idea when labor is going to end. And this is another reason why recording and studying the length of labors in different groups of women, first-time mothers compared to second-time mothers, is useful, and also define it in the manner that I've described is such that you would be able to say to a woman who comes in at 2 centimeters, first baby, whatever age, whatever BMI, other details can be added, the average, or you are likely to deliver in a certain time from our information. And I think that is very useful, because when you are stressed and during labor, when you're getting pain, knowing when the end is coming is a very useful thing to aim for and helps cope. Length of labor for the child, obviously there is a risk of hypoxia mainly in the first stage, but also in the second stage, trauma, if it's a difficult either vaginal or cesarean section, and also if the uterus is tired, where those efforts of delivery either vaginally or cesarean may be more difficult, and there's a greater chance of bleeding and difficult deliveries. Staff are often forgotten in the context of long labors, and as a junior doctor in the National Maternity Hospital, even as medical students, they're trained to sit in with women as part of their training, and just sitting with women for a long period of time does emphasize how difficult, but yet how important it is to provide one-to-one care. It is not easy providing one-to-one care for hour after hour after hour, and that's why staff get relieved and somebody else fresh comes on, but the mother is still there. But often staff can have quite negative experiences of just sitting there and being able to do nothing and just waiting and waiting. So there's another reason why prolonged labor there. But also organizational. I mean, if for every woman that labors in a delivery unit has long, prolonged labors, the difficulty in providing the standards of care that we want to, something so simple as one-to-one midwifery care, is just going to be more challenging. It is more challenging to have the right number of midwives at any one time to provide that one-to-one care. And remember, that's what we're promising women who want to deliver vaginally, that they'll have one-to-one care. The maths just doesn't add up if the longer the labors are, the most valuable resource we got, midwifery one-to-one care, we're not able to provide. Now, I, as many people know, come from a hospital whose whole philosophy began with this concern about the duration of exposure to stress of prolonged labor, both physically and emotionally. And the first paper was published way back in the late 60s. And also recognizing that childbirth has long ceased to prevent a serious physical challenges to healthy women in Western society, but the emotional impact remains a matter of concern. Prolonged labor is essentially a problem of the first birth. That's another thing to recognize. And I would go along with the view that 12 hours is considered by many as a reasonable definition of prolonged labor. That doesn't mean to say women should be delivered immediately afterwards. Some women are willing, do want to go on with labor, but I would suggest that the majority do not. And an nulliparous woman requests a cesarean section. Maternal request for cesarean section is growing and growing, as I understand it, although it's difficult to define, and another thing that's difficult to measure. But a nulliparous woman that requests a cesarean section is requesting it because of something that may happen. A multiparous woman requests a cesarean section because of something that did happen. And usually, certainly in the debriefing clinics that I do, women in labor, which we offer a weekly clinic, it's usually because of a prolonged first labor. So my view is some women will have a birth plan of minimal intervention and they will be happy or not concerned if their labor was wrong. They want to try. Some women are requesting more and more pre-labor elective cesarean section. But I would suggest to you the vast majority of women will prefer a short labor, a high chance of one-to-one care, and a high chance of a safe vaginal delivery. And if you're going to implement this, if you're going to look at your duration of labor, if you're going to use processes that are evidence-based, that's fine. But I think we've always got to remember that we have a responsibility to collect the evidence to ensure that we're providing quality of care to our patients. And I would suggest to you, duration of labor is something that our women would want and expect us to know. And I think, and I continue to say this, that I think the biggest advance in 21st century perinatal care to the mother and baby is going to be a result of better routine structured data collection, more sophisticated analysis, and improved implementation of appropriate changes, which may be different. The right processes may be different in different parts of the world and different circumstances. But prolonged labor and even measuring the duration of labor, I think we should think again, and I think it's something that we should measure because women would like that. Thank you very much. So I will stop sharing my screen. I see there are a few questions there. We'll take them at the end. And I would like to invite our second speaker to a talk. We'll move straight on, and is Eva Itzel from Sweden, who is going to be talking about dystocia. Are there different forms of labor dystocia? Should they be treated differently? Thank you, Eva.
Dear friends, my name is Eva Itzel. I'm an associated professor and senior lecturer at Karolinska Institute in Stockholm. I'm also a senior consultant at the Women's Clinic at Surbek. I will, these coming 20 minutes, talk about labor dystocia and if there is different forms of it and if they should be treated differently. So I will start to share my slides with you. And the message of this lecture will be if there is various forms of labor dystocia, and if we get more knowledge about this, should we treat arrested labor in different ways? Background figures from FIGO. Every year, 130 million women will be pregnant. Over 350,000 of them will die during labor. And more than 50 million women will every year have complications. And here we talk about pelvic floor injuries, about fistula and so on. 4 million neonates will die during labor, 1 million of them due to asphyxia. All those things have something in common, and that is an arrested labor progress or labor dystocia. And labor dystocia is a huge problem worldwide. This is a picture of what is happening in normal labor. The myometrial circulation will be turned off at every contraction. And then the metabolism will be shortly be anaerobic. And lactate and other metabolites that are associated to hypoxia will be produced. But after the contraction goes away, new fresh blood will be brought to the muscle and take a lot of these metabolites away. I have a close collaboration with Professor Susan Ray in Liverpool. They are doing a lot of experimental studies on uterus. And she says that the uterus needs this coordination between levels of lactate, hypoxia, and oxytocin. Those things, they trigger to the next contraction. So this is physiology. It needs to be like this when you have a normal labor. But when we have a labor dystocia, something happens, and we still don't know what or why. You have irregular contractions, and it leads to prolonged hypoxia. And if you have a prolonged hypoxia, the accumulation there will be an accumulation of lactate and a decrease of pH in the tissue. And if you have an acidification, the influx of calcium into the myometrial cells will be inhibited. So the result of this will be that the woman will have contractions, but they will be weak, and it will be what we in clinical practice call a dystocic labor. My research, this is not my research, this has been done, for instance, by the group of Professor Ray. But my research is more clinical, and it says that if you have lactate in the tissue of the uterus, this can be transported to the amniotic fluid, and you can analyze it at the bedside and get information about the uterus. So I have a clinical part of it, and Dr. Ray has the more physiological experimental part. And during labor dystocia, this is how it is today. We have the patogram. You know that WHO says that every delivery in the world should have a patogram. And we have oxytocin, which we hope could help the woman to get normal contractions. But on the left side, you can see the risk of hyperstimulation, the risk of fetal morbidity, the risk of postpartum complications, and also very important, woman's experience. On your right side, you can see our desire of a spontaneous vaginal birth. And as I said, the help today is the patogram and oxytocin. How it began. I was a PhD student at the Karolinska Institute, and I defended my thesis in 2007. In my thesis, we had a big randomized control trial where we compared lactate in fetal scalp blood with lactate with pH in fetal scalp blood. This was a big randomized control trial. But at the same time, we made this one, a pilot study where we looked at 100 deliveries, where we took one sample of amniotic fluid and one sample of fetal scalp blood and analyzed the lactate level. Because my supervisor, he knew that there were lactate in amniotic fluid, and he thought that we could use it instead of taking a blood sample. And as you can see, this is the picture of it. There is no correlation. But by coincidence, I looked at the outcome of those deliveries, and I could see that almost everyone who had a normal delivery also had a low level of lactate just before delivery. And almost everyone who had an operative delivery due to dystocia had high levels of lactate. Then we made a second part of this. We had one woman in our clinic. She was overweighted, so she needed a koala catheter for measuring her contractions from the inside. And I realized that you could sample amniotic fluid by this catheter. I sampled it in the crane. You can see the red mark on your picture. And I sampled amniotic fluid every 30 minutes during labor in 75 deliveries. And we analyzed it blinded, and we compared the frequency of spontaneous vaginal delivery versus operative delivery due to dystocia, and then the AFL, amniotic fluid lactate. And this was the result. You can see again the same as we saw in the first part of the study. Almost everyone who had a low level of almost everyone who had spontaneous vaginal delivery also had a low level of lactate in their amniotic fluid. And those with operative delivery had a high level, this is the red one. And this is sampling, first sampling, 30 minutes later, the second sampling, and so on. So this was the first time an association between high AFL values and operative delivery due to dystocia was shown. This was in my thesis, and it was published in Act of Obstetrics 2008. Afterwards, we made an ROC curve and deconstructed cutoff values, because we thought that if this should be used in obstetrical care in the future, we need to have cutoffs. And we could see that if you have less than 10.1 in your amniotic fluid, just before oxytocin was started, you have a high chance of a normal delivery. You could also see that if you have a high level of lactate just before oxytocin was started, the risk of an operative intervention in the end was increased. Then we made something called the dysfunctional labor study. This was from the beginning a Swedish study. It was 4 clinics from Sweden, Uppsala, 2 from Karolinska Institute, and 1 from Umeå. Then I was to a congress, and I met 2 guys from Switzerland, and they asked if they could join this study. 1 from Basel and 1 from Aarau. I said, of course. And then I met a guy from Paris, from PPH, which is a clinic in Paris, and he asked the same, and I said, of course. Then in the end, I met a guy from Tanzania in Africa, and from Dar es Salaam, and he wanted to join us, and he did. And then this study was funded by Bill and Melinda Gates Foundation. The method in this study was that the midwife was collecting fluid during normal vaginal examinations. She took a few drops of amniotic fluid which was coming out and sampled it. And we took it when women attended delivery ward, when oxytocin was needed, and at delivery. AFL was analyzed blinded, and then everyone put in the data in a common database called dystocia, which was on the internet. 87% of deliveries had a normal level of AFL just before oxytocin was started, and 91% of those had a normal vaginal delivery. 13% had a high level of AFL when oxytocin was started, and only 10% of them had a normal vaginal delivery. We could also see when we made the logistic regression that high levels of AFL just before augmentation had an increased risk of 4.5 to have an operative intervention if the level of AFL was high. Okay, so this dysfunctional labor study, it was a couple of years ago, but today we went back to this material because we have new questions. Are there different forms of labor dystocia that are unknown? Should we treat these deliveries differently? Because we had looked at those with extremely low values of AFL. And the question is this a different form of labor dystocia? As I said, I had a good research collaboration with the research group in Liverpool under Susan Ray. And this is a paper from her group. It's an old one, you can see 1995. But in this paper, they showed that the uterine muscle contraction is changed if you manipulate the intracellular pH. Acidification can abolish contractions. Alkalinization increases contractility. They also showed that just a couple of weeks, the last week before labor starts, a significant alkalinization of the uterus muscle occurs. For me, this is a way of preparing for the uterus to prepare labor, because during labor it will be an acidification by the lactate, and this is a way of preparing for that. But my question is, will some women have too much of this? We went back to dysfunctional labor study again, and here you can see 1,299 amniotic fluid samples. You can see to your left, most of them is in the middle group, but you have a low group and you have a high group. And the right one is the AFL levels at delivery. Again, most common is the middle group, but you have a low group and a high group. Then we divided these groups of the value of the sample that was taken just before delivery. And we could see those in the low group had a cesarean section rate of 9.4, and the use of oxytocin was only 14%. Median value, cesarean section rate 5.8. It's almost the half of the low group. And the use of oxytocin, 67%. Values of high values of AFL, cesarean section rate, or the cesarean section rate is not as high frequent as in the high group, but they're still there. And one thing, the use of oxytocin is really, really low. And the question is, should it be like that, or is this some kind of missing from us? To not stimulate this group. So we looked again at the group with low levels when they come to delivery ward, but those who stayed extremely low through labor. We could see that 219 of the women had a ride, and 140 of these, 64%, remained low through labor. The use of oxytocin was lower in that group, but we could see cesarean section rate of 10% compared to 2.6 in the group where the level was low but increased during labor. So for me, the question is, do we handle these labors incorrectly? Alkalinization leads to increased contractility, Susan Ray says, but not necessarily increased strength of contractions. So my question is, are we using oxytocin in the wrong way in this group? Should they have more oxytocin to get them a little bit more, acidification of the uterus muscle, to get it more to the normal group of AFL? Take-home message: middle group of AFL, most common, with an adequate use of oxytocin, will most of these deliveries end spontaneous vaginal. High levels of AFL, small group, strong correlation to an operative intervention, even with an adequate use of oxytocin. But now we found a new group, a low group. More research needs, of course, but should we treat these deliveries differently? The reason for the halted progress is probably another than those with high levels, where we talk about an exhausted uterus. That's the question. So thank you for your attention, and if someone will reach me or mail me or talk to me in some way, you can contact me on my details. Thank you.
Hello. So thank you very much. We'll go on to our next speaker now. And our next speaker is Dr. Daniel Surbek, who is going to talk about VBAC. Is VBAC still an option? Thanks very much, Daniel.
Thank you very much, Mike. I will quickly share my screen and then we can start. All right, so I hope you can well see my slides and hear my voice. I will, within the next around 20 minutes, speak about the question if the vaginal birth after cesarean section is still an option. So the epidemiology of VBAC is certainly very interesting. As you know, in earlier times, everybody said once a cesarean, always a cesarean. This then has changed, and this is the graph of the development of the prevalence of VBAC in the United States. And you can see here that around the 80s, there was a very low rate of VBAC and of trial of labor. This has changed in the early 90s with a peak of almost 30% of women with previous cesarean section in the mid-90s, but then there was again a sharp decline, which is ended around 10% only, and this is data of the United States. In Europe, of course, things are as very often different. You can see here data with the survey of over 10,000 pregnancies with previous cesarean section in Switzerland. And there we compared also 2 time periods, end of 90 years, and then we can see here that already 5 years later, with a similar descent of the number of women who tried trial of labor. However, the level is still quite high, so that means that around now there would be around 60% of women who will undergo a trial of labor, and this is still the case in the current times. However, the the prevalence of induction of labor in these women has decreased and is around 10% only. So what is the most prominent indications for cesarean delivery in patients with a previous cesarean delivery? Of course, it still is the previous cesarean section. So what can we expect from a trial of labor after cesarean section? In general, there are rather high differences between countries, as you have seen, but also between institutions. But if you want to have an overall estimation of the success rate of a trial of labor, this would be most probably around 75%. And if you want to have a number estimating the rough uterine rupture rate, there you would end up with around 0.5 to 0.7% in those women with a previous cesarean section who undergo a trial of labor in the next pregnancy. So the risk of VBAC, of course, are mostly the consequences of severe complications such as the uterine rupture. And you can see here the landmark study of London, which has shown that there is a significant difference of the incidence of hypoxic ischemic encephalopathy of newborn, which differed in the group of women who underwent a trial of labor as compared to those who had a repetitive cesarean section. And the difference was actually, as you can see here, significant. So it's 0.08 versus 0 cases in this collection. That means that there is a significant difference in this complication. However, the incidence is still very small. What is also significant is the difference in number of antepartum stillbirths, and this, of course, are mostly those ones who are around term in those women who were awaiting the onset of spontaneous labor. What is also has become clear as that maternal complications probably are lowest in all choice if there is successful vaginal delivery. However, they are highest if there is a failed vaginal delivery. And these numbers also outlay those numbers which you find in women who have a primary elective repetitive cesarean section. That means that the aim must be really to choose those women who have a reasonable chance to achieve a vaginal birth if they try a labor, and not to have too many of those who will in the end have a successful vaginal, a failed vaginal delivery, and in this case have more complications. So what are the predictors we know of successful vaginal birth, but also predictors eventually of severe complications such as the uterine rupture? Here we have some first data showing that the previous vaginal delivery is one of the most important positive predictor, but also a low birth weight of the baby. If onset of labor was spontaneously and not induced, and also the indication of the previous cesarean section was of importance, as well as the body mass index. And if you, for example, take here, suppose that you have a high body mass index and there is also a low, an indication of labor necessary, you will find a success rate which is below 50%. So BMI, in fact, does have a significant influence here. That means that it's inversely correlated with successful VBAC in univariate as well as multivariate analysis. Preterm birth also logically would have a higher success rate, mainly, of course, because baby's weight is smaller in preterm birth. That means there you have an average estimation of success of over 80%. If there is a previous vaginal birth, there is a particularly high rate also, specifically if this vaginal birth was after the previous cesarean section. That would mean that if there was a previous successful VBAC, there will be a success rate of a vaginal birth in the next pregnancy of over 90%. What about with in women with two previous cesareans? Success rate here is somewhat lower in this study, and risk of uterine rupture was somewhat higher. There is other series published like this one. This was just recently published, where the success rate was clearly lower, around 40%, and there was a severe maternal morbidity rate of 2%, which did not only include uterine rupture cases. So what about the induction of labor after a cesarean section? We all know that the prevalence of induction is still rising and reaching in some countries 30%. So this is a significant question we will face in daily practice, where we need to have a reasonable approach to. So do we have evidence of induction of labor after previous cesarean section? The answer, unfortunately, is no. As you can see here, there is no randomized controlled trials identified, which are reasonable numbers and concluded. You can see here that the Cochrane looked at this in 2012. 5 years later, still nothing has happened. So we still are here left with case series with cohort studies. And these show, of course, that in general, success of VBAC decreases and the rate of the risk of uterine rupture increases if labor needs to be induced in women with a previous cesarean section. So there's a consequence, of course, we need to be very critical if we indicate a labor induction in these women. And that means also, of course, that we should reduce absolutely those cases or those induction which are not really medically indicated and which are on demand, of course. So the induction after cesarean section, the success rate varies among studies quite a lot. In this series, it was 63% vaginal birth. And the risk of uterine rupture was 0.7%. In a meta-analysis, they showed that there is also dependence of the method how labor is being induced. That means that those women who received oxytocin, that means that those ones who had a advanced Bishop score, that they had a higher success rate in these meta-analysis. Another study looked also at different methods, oxytocin with or without prostaglandins, and they showed that there was in fact a difference. However, if they looked actually at the overall numbers, it became clear that it is more the question if there was a prior vaginal delivery, if the woman would have success or not. And you can see here on the left side, if this woman does not have a prior vaginal delivery, and if labor was induced, there was a success rate around 50% only, with a 1.5 uterine rupture rate. And this was also the case not only in those women induced with prostaglandins. And here, if there was spontaneous labor, the success rate was higher. And the best rates you achieved in those women who had a prior vaginal delivery, where induced labor rate was a rate of success was 83%, and in spontaneous labor almost 90%. That means in general that induction of labor cannot taken by itself as a predicting factor, but you always need to combine it with a much stronger predictor, which is in fact a prior vaginal delivery, yes or no. What about severe complications? Uterine dehiscence or uterine rupture probably will be the most severe ones. At this point, I just want to remind you that the most frequent sign during labor that there is a uterine rupture, most frequent clinical sign is with 78% fetal distress. And many women do not have vaginal bleeding with rupture. In many women, there is no change in abdominal pain during labor. And that, of course, means that that it is of absolute importance in these women to make continuous CTG, fetal heart rate monitoring, to really be able to detect uterine rupture early enough. As you can see here, there is even some cases of completely asymptomatic uterine ruptures during pregnancy, before labor. Like in this patient, she had a little bit of abdominal pain. She went to the emergency of surgery, and they found that there was already ruptured lower segment. But you can see here the hand of the baby has a nice color. That means there was first no bleeding within the abdomen, and second, the baby was in good condition when the cesarean section was right performed. So that means that there is also some uterine rupture cases with a very low overall morbidity in women and in the children, but this is certainly not the most frequent one, but it also can happen. In this series, they looked at the differences in uterine rupture rate according to the mode of induction of labor. And as you can see here, and this is the incidence per 1,000, if there is spontaneous onset of labor, the rupture rate was 0.5%. If the labor was induced, it was 0.8%. And if they're induced without prostaglandins, and if the labor was induced with prostaglandins, the uterine rupture rate achieved 2.5%, which is a threefold increase in these over 20,000 patients case series cohort study. Of course, there were some problems within this study regarding the appropriate diagnosis. Of course, the question of which prostaglandin was used. Were there patients with who were being induced with misoprostol? But overall, it became clear that there is an increase here in uterine rupture if prostaglandins are being used. So another issue, of course, regarding the risk of uterine rupture is the short interpregnancy interval. That's also why counseling after a cesarean section regarding this interval is important. That means that the longer the interval is, the better or the lower risk you find in the subsequent vaginal delivery regarding uterine rupture. Of course, we all know the differences of rupture rate according to the previous cesarean section technique. So the classical length uterotomy, the corporal uterotomy, has quite a high rupture rate as compared to the used transverse isthmic uterotomy. What about the suture technique? Meanwhile, there's a lot of papers being published. This is one of the first ones by Ilya Bouchold, and he showed at the time, or he suggested that there may be a difference regarding uterine rupture risk if there is only a single layer closer in the previous cesarean section of the uterotomy as compared to a double layer suture. However, in the subsequent studies, this difference was not able to be confirmed clearly. That means that this is not really at the moment a question. That means that there is no evidence that the double layer at the moment is better regarding this outcome. Now, what about the prediction of uterine rupture regarding the technique of ultrasound measurement of the lower segment? Here also there are several studies being published showing that if the lower segment is a minimal of 2 millimeters, that eventually the uterine rupture rate may be lower. These data are again not so clear. There are some differences also in the measuring technique. So for the time being, this thickness of the lower uterine segment is insufficient to be able to clearly predict which woman has a high risk of uterine rupture and should not undergo a trial of labor. So I don't go in too much into the different techniques of labor induction. I just want to mention at this stage, of course, one point is that there is again one Cochrane review stating that there is insufficient evidence regarding the question of the method of labor induction. There were 8 studies, but all 8 studies were had rather low number of patients included, and they all compared different methods of induction of labor. So the authors were not able to really come up with the meta-analysis of these data. That means here we are still very bad with the evidence. On one side, we know what we should not use, and this is the use of misoprostol, whatever route of administration, vaginal or oral or whatever, this should be omitted, as data suggests quite clearly that there is a rather high uterine rupture risk with misoprostol. One question, of course, is what about mechanical methods in this clinical situation? Use of Foley catheter or double balloon catheter. There is some evidence because we know of different other studies in women with no previous cesarean section that the hyperstimulation rate using mechanical methods is the lowest in with all induction methods, and probably that's also the rationale why this should be used. However, as this study shows, this study we have done published recently in a cohort of women being induced with balloon catheter after a previous cesarean section, we found a success rate of only 46%. So I think that's a problem if balloon catheters are used in women with previous cesarean section. There is no study showing that success rate would be over 50%. Summary, a detailed explanation of chances and risk according to individual situation must be done. Of course, if decision to induce labor, in this case, probably balloon catheter should be preferred, but women must be, of course, informed that success rate is is rather low. If prostaglandins are being used, there should be used only with cautious. Americans, I think in the United States, it is not recommended to use prostaglandins. In several European countries, prostaglandins are being used, the dinoprostone, in this situation, but with higher caution, of course, and appropriate fetal surveillance during induction of labor. So that's a summary of chances and risk, which we just discussed. And regarding predictive factors, you have heard there is, of course, the cervical score is important if labor is induced, spontaneous labor, previous vaginal birth or previous successful VBAC are probably the most important predictors. Maternal weight and height, so the BMI is important. And of course, also the indication for the previous cesarean section, if this is not dystocia or not failure to progress, there in these cases, there is a higher chance of a successful vaginal delivery. You can use also the MFM network VBAC calculator, where you put in basically BMI, the ethnicity, any previous vaginal delivery or previous VBAC, and the indication of the previous cesarean section. So that means you put in only the strongest predictors, and then you can have a calculation with these points. Of course, it will never be an exact calculation. However, this has been reproduced in several studies and found to be rather appropriate. So what about the risk factors of uterine ruptures? To summarize, it's labor induction with prostaglandins, it's a small, short interpregnancy interval, an advanced maternal age, the technique of the previous uterotomy is important. Also, if the women had postpartum fever and infection of the uterine scar in the after the previous cesarean, and the number of previous cesarean section also does play a role in this. So recommendation of ACOG for VBAC, women with one previous cesarean section should be after VBAC after appropriate informed consent process regarding chances and risks. I think here it's also that today even women with two previous cesarean sections can be offered a VBAC. And what is important is the second part, that VBACs should only be performed in hospitals appropriately staffed with necessary infrastructure for rapid emergency cesarean section. So in the end, as we know, the risk is always in the eye of the beholder. That means that a risk of hypoxic ischemic encephalopathia in the newborn of 0.08% is really low, because this also needs to a number needed to treat to avoid one of these cases of 370 cesarean section to be made to just avoid one HIE in the newborn. Of course, from a medical point of view, this is a very critical NNT and shows that it's absolutely does not make sense from a medical point of view to avoid all VBACs. So the counseling must take different aspects into account. This is risk and benefits for the child, of course, also for the mother. Then you need to assess does the woman wants to choose elective C-section? What happens if she chooses a VBAC, a trial of labor? What are the complications for mother and child if successful, and what if it's not successful? And then there are, of course, also long-term outcomes from cesarean sections, such as placental accreta spectrum. And also in the end, there is a need of integration of family planning aspects. Is it the last cesarean section of the women? Does she want to have sterilization at the same moment because she already has 3 children. This is also one of the arguments. So it's a lot of different arguments you need to take into account. You need to take time yourself to counsel women. And my last message, of course, is that there is also a mode to avoid the question of VBAC by preventing the primary cesarean delivery. And as you can see here, the indications of primary cesarean deliveries, there are 1/3 is only labor arrest, and there is almost 20% malpresentations, and the rest is mixed. So I think we need to take this into a focus to have a better approach to avoid the primary cesarean section in the first place. So with this, I'm finished. I want to thank the audience for listening, and I'm open to questions, online questions. Thank you very much for your attention.
Thank you very much. We'll move straight on now to Dr. Erez, who is going to talk to us about management after hyperstimulation. Offer, please.
Thank you. Good afternoon. I'm going to share my slides, my screen. Good afternoon. I'm going to speak today about management after hyperstimulation. Well, the onset of labor is a complex process, which is a combination of fetal, placental, and maternal pituitary interaction that reduce the inhibitory effect of progesterone production of increase the production of oxytocin, and increase the receptivity of the uterine to that effect of oxytocin, leading to uterine contraction. These contractions need to be synchronized, and the effect goes in all levels, from the myocyte to the myometrium and to the organ level of synchronized contraction of the entire uterus, leading to parturition and then to delivery. If we can see the difference in the myocyte between the early term and the full term, so the early term, the action of the myocyte is non-synchronized. There is not enough gap junction, and the effectivity of uterine contraction is not that well. Well, if you look at the full-term uterus, you see highly synchronized contraction and most effective contractions. People try to image that contraction, and this is a sheep model done by Wen Jai-Wu and his team, and this was published last year in Scientific Translational Medicine. And what they did is that they took a sheep model, they do an MRI scanning of the uterus, divided into regions according to the MRI imaging, put electrodes on those regions, in those regions, creating an MRI imaging of the uterus, then activate the uterus by electrode, and receive a picture of how the uterus contract, and imaging of the contraction of the uterus. And this is how it looks in real life when they did on 3 different time periods of uterine contraction, where there is a center of activation of contraction and the expansion of the contraction towards different areas. Now, the uterus has several pacemakers in it. And when the contraction starts, it starts from a single pacemaker that increases the pressure in the uterus, and then recruits one pacemaker after the other. As long as the pressure increases, we have more pacemakers recruited. Now, this leads eventually to a synchronized contraction and effective contraction of the uterus, and that is how we get a very effective labor. When we have contraction, with the progression of uterine contraction, we have a reduction and cessation of blood flow into the uterus, and maternal blood flow, and a decrease in fetal oxygenation. However, when the timing of the uterine contraction is normal, and there is not more than 5 uterine contractions per 10 minutes, the fetus, most of fetuses sustain very well the hypoxic and reoxygenation cycles associated with labor. But when you have uterine interstitial, actually the uterus goes wrong, And when we have more than 5 contractions in 10 minutes, and this is the definition for over 30 minutes, this is the definition of the ACOG, we have a uterine tachycystola. Now, that is associated with maternal morbidity, maternal fetal morbidity, and we can talk about that today. What is the epidemiology of uterine tachycystola? The most updated report and the largest report is found by Karahauser and their associates, and that is published in the American Journal in 2013. And they wanted to study the incidence, what the fetal heart rate changes, and what is the effect on the mother and the neonate. Out of 50,000 deliveries participating in their study, there were the prevalence of tachycystola was about 10%. Of them, 7% were with only a single event of tachycystola, and the rest was more 2 or 3 or more events. When you see the clinical characteristics of the patient, there were more patients with hypertension, more patients who had preeclampsia, more of those who had oligohydramnios that were experiencing tachycystola events, and the majority of those patients had either elective or indicated induction of labor. Now, the type of induction was mostly oxytocin, followed by misoprostol, and the minority had Foley catheter. A different study by the team, combined team from Michigan and New York, studied uterine tachycystola in spontaneous labor or term, and they were showing that mother who had tachycystola were younger at age, had larger fetuses, had higher rate of oligohydramnios, and were nulliparous patients, and that is important for the next. Another risk factor for a uterine tachycystola was the presence of uterine leiomyoma. In a study from a large cohort in Israel, you can see that the crude odds ratio after adjusting was the adjusted odds ratio after adjusting for nulliparity, prostaglandin induction, and oxytocin augmentation was 21.8. So when a woman has a leiomyoma and she goes into labor or she's been induced, we need to take that into account. When we do labor induction uterine tachycystola, with the prevalence of induction all over the world is rising, and where it's 4.5% in the center of Africa, it reached 23% in the United States. And if we look at the number of the United States, we can see that it more than doubled itself from 1990 to 2005, and especially during term pregnancies. Now, we use in induction mechanical methods such as double catheter Foley balloon or laminarias, and a pharmacological induction either by oxytocin or by prostaglandins. The prostaglandins are the leading method of induction, and if you can see the change in the responsiveness of the uterus to a prostaglandin during gestation, we can see that during the beginning of pregnancy, a single dose of prostaglandins needs to be very high to be effective and it is safe. But when we go past 30 weeks of gestation, a very small dose of prostaglandin is effective, and a higher dose can be dangerous and lead to unwanted side effects. And the rate of hyperstimulation was 7.3% among those who were receiving prostaglandin intravaginally, at tablets of 300 milligrams. It reduced to 2.9% to those who received intravaginal gel, and to 0.5% to those who received intracervical gel of prostaglandin with decreasing concentrations. Now, when it was compared, when a Cochrane study was done and a meta-analysis, there was clearly that administration of Foley catheter was associated with almost more than 70% reduction in the incidence of uterine hyperstimulation in comparison to prostaglandins. Moreover, the most potent prostaglandin in terms of generating uterine hyperstimulation is vaginal misoprostol. It creates or generates more hyperstimulation events than vaginal dinoprost, oral misoprostol, intracervical dinoprost, and of course Foley catheter. And as much as for oxytocin induction, we know that there are more than two protocols, but you're using either low dose or high dose oxytocin to induce labor. The prevalence of uterine tachysystole is about 5%, and the most frequent complication is non-reassuring fetal heart rate tracing. In a Cochrane review that tried to test the effect of oxygen augmentation in labor in women with epidural analgesia for reducing operative delivery, it found no association. It was only one study, and there was no association with uterine hyperstimulation. When were 4 studies included in the comparison of high dose versus low dose oxytocin in the incident of hyperstimulation, there was no effect. However, a study published this year in the Journal of Perinatal Medicine did a meta-analysis and compare, or already had 900 cases in each arm, and in that meta-analysis, a high dose oxytocin was associated with a significant increased risk, almost double the risk for uterine hyperstimulation than a low dose oxytocin. So if we summarize, there is a strong association between pharmacological induction of labor and uterine tachysystole. Vaginal misoprostol and high dose oxytocin regime are associated with the highest risk for uterine tachysystole. But what is the effect of tachysystole on maternal and fetal outcome? This is a study from 2008 from the American Journal of Obstetrics and Gynecology, and they were studying the effect of oxytocin-induced hyperstimulation on fetal oxygenation and fetal heart rate pattern. What they did is they used 2 cutoffs. One is between 5 to 6 contraction per 10 minutes for more than 30 minutes, or more than 6 or more contraction in 10 minutes for more than 10 minutes. The preceding 30 minutes of normal uterine activity was used as a comparison group, so each patient was a control of its own. And what they did, they inserted a probe that measured the fetal O2 saturation during labor following rupture of the membrane and showed the effect. Well, you can see that those who had less than 5 contractions per 10 minutes maintained very nicely, the fetus maintained very nicely its oxygen saturation, while when they had between 5 to 6 contractions to 10 minutes, they had a decrease, and that decrease, it was even stronger when they have 6 or more contractions. Now, this has also affected the fetal heart rate patterns because we had recurrent deceleration, a late deceleration, and minimal variability more prominent in patients who had 6 or more contractions in 10 minutes than the other study groups. Oops. The authors then concluded that hyperstimulation is associated with negative effects on fetal status, and the more contraction that you have in 30 minutes, or the more pronounced is the effect. Now, if we go back to the study of Kara Hauser, we see that the effect of hyperstimulation and tachysystole on the mode of on the type of delivery was associated with a substantial increase in operative vaginal deliveries. And so they wanted to study the effect on fetal heart rate monitoring subsequent to their finding. And they divided the groups into 4 subgroups. Those who had only tachysystole, those who had tachysystole with a change in the fetal heart rate category, those who had tachysystole with a need for intervention, either administration of terbutaline, or the change in oxytocin dose and or a position change, and those who had tachysystole that necessitated delivery, either by cesarean or instrumental delivery. The rate of each group was that 17% had only tachysystole, 32% had a fetal heart rate tracing category change, 38% needed some intervention during labor due to tachysystole, and 13% needed expedited delivery. When they studied the risk factor for tachysystole as the whole, as a group, so there was, of course, oxytocin, misoprostol, use of epidural, induction, whether it is indicated or elective, are all associated with increased risk for tachysystole. Also hypertension and preeclampsia. What was interesting is that multiparity, being married and being younger than 30, and being over 30 years old, had all protective effect versus the development of tachysystole. Similar effects were recorded when they looked on tachysystole with fetal heart rate category change. The NA stands for non-available because they used a backward logistic regression method, and the parameters written NA were excluded from the analysis. This was similar when they used for any fetal intervention during labor, but those who needed expedited delivery were only those who had oxytocin as the major labor induction method, while multiparity and being over 30 years old had a protective effect against that. When they studied the effect of a tachysystole group on neonatal outcome, you could see that all the subgroup were associated with an increased risk for NICU admission of the neonate, but the composite adverse neonatal outcome was significantly higher only in the tachysystole group, or those tachysystole that needed intervention during labor. And the author concluded that tachysystole is associated with specific risk factors and impacts fetal heart rate and neonatal morbidity. Now, how to manage uterine tachysystole? Well, there is a very detailed mini review published by the group from Toronto. The leading author was Robson about that, and that was published last year in the Journal of Perinatal Medicine. And they suggest that if you have a fetal heart rate category 1, decrease the dose of oxytocin, but continue to observe the patient rather than doing anything else. However, if you have a fetal heart rate category 2 or 3, or you change to go into one of those categories, then you should reduce or stop completely your oxytocin augmentation. If that is the case, put the patient in lateral repositioning, add oxygen, IV fluid, and if necessary, also amnio infusion. Now, if that doesn't help, consider to add tocolytic medication, either terbutaline 250 micrograms subcutaneous or intravenous, or nitroglycerin sublingual spray on 400 micrograms. And that should resolve the tachysystole within minutes. Now, there was a Cochrane review about acute tocolysis to suspect for uterine tachysystole. And what it shows is that if you compare beta-mimetic adrenergic agent to no tocolytic treatment, there is sustained reduction in the fetal heart rate tracing abnormalities, but it doesn't change the 5 minutes Apgar score or fetal death or neonatal mortality. So the treatment is effective during labor, but doesn't change the fetal and neonatal outcome eventually. Now, terbutaline is more effective than nitroglycerin in improving and reducing the rate of uterine tachysystole. Tachysystole also had a medical legal aspect. This is from a website of a law firm in the United States, in which they explain what is tachysystole to their client, and then at the bottom of the page say tachysystole, medical malpractice, and legal help, connecting tachysystole to medical malpractice with the feature video of hypoxic ischemic encephalopathy and cerebral palsy. So we can need to take that into account as well. So the recommendation, and I'm quoting the study of the review on Robson, is that we need to be professional in labor management and understand labor physiology in order to not to get to the point we would have tachysystole. There need to be specific clinical guidelines and protocols about how uterine contraction should be followed, on what frequency, and who should receive continuous follow-up. There should be early identification and timely management of the uterine tachysystole in the labor ward. And if there is a fetal heart rate changing, that requires intrauterine fetal resuscitation and changes in the practice of induction if that is happening during that time. What is very important and can help in a prevention is strict guidelines and protocols of oxytocin administration during labor in the labor and delivery ward of each department. Having such a fixed protocol, usually taking the low dose rather than the high dose protocols, will reduce substantially the amount of tachysystole event during labor. And a one-to-one nurse to midwife to patient ratio is very important in achieving all this. And I know it is somewhat difficult, but that helps to observe the patient and to early diagnosis and management of tachysystole. Thank you for your listening and for attending the meeting.
Thank you very much, Ofer, and for sticking to time too. So we move straight on to Dr. Kalache from Qatar, who's going to talk about posterior rotation and asynclitism. Thanks, Karim. Go ahead.
Yeah. Let me try to share So you should see the screen.
Yes, we can.
Yeah, can you hear me and can you see the screen?
The screen
Yes.
is gone.
Ah, is it? Okay. Is there now?
Yes, go ahead.
Okay. So my talk is about posterior rotation and asynclitism. And first of all, I would like to thank Dr. Romero and Dr. Giancarlo Di Renzo for inviting me. And I will try to keep the time. The talk will be very practical. And I have nothing relevant to disclose, no financial interest and so. And I have just want to say something. When I moved to Qatar 6 years ago, or more than 6 years ago, I was really hoping to apply some of the research we were doing back home in Berlin, especially combining ultrasound for the diagnosis of these abnormal conditions. I was hoping because I started working in an institution with more than 18,000 deliveries a year. This is the Hamad Hospital in Doha. And I realized soon that there are other priorities than, you know, performing ultrasound in labor. And, but I hope to do it in the future, maybe at the institution I'm working now. So, but the research I'm going to talk about was collected at the Charité Hospital in Berlin, and it's about malposition and asynclitism. So the occiput posterior malposition, the occiput posterior malposition, is a common reason for delay in the second stage of labor. It is actually, with the rising rate of cesarean section in the second stage of labor, the commonest indication to perform a cesarean section at this stage of labor. Basically, a malposition, asynclitism will be the commonest reason to perform a cesarean section. Now, the option are not always a cesarean section if you have an occiput posterior malposition. So you have the choice usually between two things. You should have the choice between two things. One is to perform instrumental delivery, and the other one will be to do a cesarean section. And I will come to other possibilities in a moment, but you should either choose between an instrumental delivery, of course, give more time, or to opt for a cesarean section. Now, if you take the wrong choice and you start with doing an operative vaginal delivery and you fail, because these are difficult situations sometimes, you have to know that you will raise the rate of complication. For example, if you start with the vacuum delivery, in this study published in the New England Journal of Medicine, Towner and co-worker have shown that if you start with a vacuum delivery, the rate of brain injury, of intracranial injury is 1 in 860. But then if you move to a cesarean section, you will increase the rate of complication to 1 in 300. So it's not a good thing to do, to start with one mode of delivery and then to move to another one, because you realize you took the wrong decision. These are the instruments you can use. Basically, the Killian forceps, which was initially developed to deliver the unengaged head, but something very important, the goal when you perform a Killian forceps is to rotate the head. So you are starting with an OP position and you deliver in an occiput anterior position. This is the role of the Killian forceps. It has no curvature. This is why you have to rotate first, and then you apply a second time and you deliver in an occiput anterior position. If you are not familiar with the Killian forceps, you can perform a rotational ventouse, but very, very important. I followed the course about the ventouse. The most important is really to place the cup over the flexion point. and in occiput posterior position, the flexion point is back. So you have to push the cup to the back of the vagina and to place it in the right position, to rotate the baby and to deliver in an occiput anterior position. By increasing the flexion, usually the head will rotate and you deliver in an occiput anterior position. Now, these are the other options. You can also do a manual rotation, and then deliver either by ventuse or forceps with a direct traction. Or what many of my colleagues tell me, look, I'm going to do a ventouse or a forceps, and I just, pull out the baby, and most of them will just come in an OP position, in an occiput posterior position. Now, I have also a colleague that told me about the ventouse or forceps with direct traction, just ignoring the fact that it's an occiput posterior position. They are associated with a higher rate of third and fourth degree, because you are going to pull out the baby with a bigger diameter. And this is something you should tell to the patient. And I remember some lawsuit in Germany back some years ago, where the woman was not told that it was an occiput posterior position, and the obstetrician just delivered in occiput posterior, had a third degree tear, and then with all the consequences, and it's not really something optimal to do. So these are some pictures I took from the internet. A baby post forceps delivery obviously was in transverse position. You have a lesion of the nose. Then this baby was tried to be delivered with the flexion point, with the ventouse not over the flexion point, and you have scalp detachment. I have personally not seen those complications, but I've seen this one because the obstetrician was not aware that the baby was in occiput posterior. And then you hear there's a woman with third degree laceration, and you go take picture of the head of the baby, and many of them, the ventouse was not placed in the right position, okay? Because it's just ignoring the fact that it was an occiput posterior. You place it towards forward, you pull the baby, and you have the bigger diameter. And then I have this one where the ventouse was placed just laterally. An old case, it was also a preterm, no long-term morbidity, but not something nice to see in a labor ward. Anyway, you can say, and this is what happened, and this is why the C-section rate has increased. You can just say, okay, I don't want to get into trouble. Let's just do a cesarean section. And this will, save me a lot of trouble. Nobody will question. I will just say it was too high and the position was not good, and that's it. And this is what is probably happening, in many places in many labor wards. So cesarean section in the second stage of labor, it's an alarm sign. And when I remember when I was on call as a consultant, each time I hear cesarean section in the second stage of labor, I'm really not, very comfortable that day. This was a lady, a woman with cesarean section in the second stage of labor. You have increased risk of hemorrhage. You have increased risk of bladder trauma. You have increased risk of tears to the broad ligament, etc. So nowadays it is usually performed by with the assistance of a senior consultant, but it's not always possible. So it's something really to try to avoid, unless you cannot avoid it. Now, how can ultrasound help? There will be a little bit of ultrasound, but it's also really about talking about the concepts. So how can ultrasound help? I think it can help in having the correct diagnosis. It can help in, I would say, it's never too early to do an ultrasound. It's never too early. The earlier you do it and the better you can anticipate. And I'm going to save you all the studies that have shown that ultrasound is better in diagnosing occiput posterior position than digital examination, because it's not what about the talk is. But let's just, introduce some diagnostic modalities. And then I told you what should be done in occiput posterior position with the choice of deliveries. So it is very easy, but I want to share something very important that I've observed many times. So you start with the transabdominal ultrasound, okay? And you place the transducer above the symphysis. And there are three situations, basically. One is you are going to see the eyes looking at you. So it's occiput posterior, okay? It's late in the first stage of labor or beginning of the second stage. You are called to a delivery and you do the ultrasound, not before the instrumental delivery. Or you see, when you place the transducer above the symphysis, the transverse, the midline echo, so it's basically transverse, or you don't see anything, and it's probably occiput anterior. So if you see the eyes, the diagnosis is clear, okay? So what can you do with this information? I like this study. It's a very small number, not because it's made in Charité and it's, remember me, the good old days with Wolfgang Henrich and Ilka Fuchs, etc. But this study was a small number of patients telling us how ultrasound can be used, you know, to anticipate when you do it a bit early. So 84 patients seen at the end of the first stage of labor, beginning of the second stage of labor. And Ima Blasi, who was from Italy at that time, and she came to do a research fellowship at the Charité, it was in 2008, was scanning every woman at the, you know, to collect the data at the beginning of the second stage of labor. So what we, you know, realized, if you are in an occiput anterior position, it will stay occiput anterior until the end of labor. It will never rotate in the abnormal position. If you end up with an occiput posterior position, the spine, the position of the spine is very important. It will let us know if this baby is likely to rotate or not, okay? So the spine cannot be obtained with palpation or with, you know, asking the patient anywhere. It is a diagnosis with ultrasound. So you see where the spine, and I will show you two examples in a minute. So if the spine is lateral or anterior, this baby will rotate from 23 occiput posterior position, 16 fetuses with the spine that was lateral or anterior rotated in an occiput anterior position. So it's good news. So now if the spine is posterior, back to back, so you have the fetal spine in contact with the maternal spine, the rotation in an occiput posterior is very unlikely. Only six babies and six babies stayed in occiput posterior and only one rotated. So a way, you know, to prevent and to anticipate a difficult delivery. And some patient may say, look, I don't want, you know, to wait until the head is impacted. Better to do a cesarean section now, and I saw it many times. So let's just go to the clip. This is an anterior occiput posterior position. I just go a bit faster. So the baby's eyes are facing the transducer. Okay, you see where the transducer is placed, and if you move below, if you move towards the spine. Let's just go rapidly. You move to the spine. You can see that the spine is lateral, okay? Is lateral, is not posterior. So this baby moved in a normal position later on. Now, the next one didn't move and required the cesarean section. So I just want to show you how an anterior occiput posterior position with the spine that is posterior looks on ultrasound. So let's start, okay? So transabdominal ultrasound. Okay, placed above the symphysis. The eyes are facing us again. Okay, this is occiput posterior. But if you move upwards, okay, if you move upwards, and you can see that the spine is back, is not on the side or anterior. This baby stayed like this, and the woman opted for a cesarean section because she didn't want any instrumental delivery in an occiput posterior. So you can anticipate by looking at the position of the spine. Now, let's look at this one, okay? This is a patient that was thought to be in occiput anterior. Second stage of labor, the head is coming down nicely, okay? Oxytocin is, you know, administered to expedite labor, okay? And then towards the end, the head was very deep, and it was supposed to be an occiput anterior, okay, occiput anterior, and then an ultrasound was performed, and the ultrasound showed that the head is very deep, very deeply engaged below the symphysis. There is a caput here, but there was something wrong with this image. If you're not experienced, is really, this ultrasound is good, but you need some experience to perform it. And nice angle of progression, everything looks fine, and the delivery is started, okay? And the junior assistant is performing a ventouse because he was told it's very deep and you don't have to worry. The ventouse was placed. Then they realized, the consultant came and they realized something is going wrong, okay? They cut the episiotomy, okay? So the episiotomy is cut, and then the baby is delivered with a lot of effort, a lot of pulling, with 4 hands on the perineum. And you can see the reason why, because it was an occiput posterior that was not recognized despite the application of ultrasound. So I would like just to say, be careful of the head that is deeply engaged when you cannot see the eyes anymore above the symphysis. This is the picture. And only an expert can recognize that the eyes are somewhere here by looking at the structure inside the brain, corpus callosum and posterior fossa and the cerebellum. Only an expert can diagnose. So occiput posterior just before the delivery is sometimes challenging to diagnose with ultrasound, okay? So it's better for me, what I told you at the beginning, to do it earlier, because the earlier you do it and the better you can anticipate. So now I will just move to the, so remember, a deeply engaged head that looks nice but is not coming can be an occiput posterior position, and all this angle calculation which we have done with ultrasound do not apply to this situation. Now, the last few slides is about asynclitism. When I was giving the talk, I thought, I was so embarrassed because the Mr. Asynclitism really is Antonio Malvasi from Italy and Tullio Ghi. They published all the papers about the subject, about asynclitism, and I have to tell you, I never really understood, what is asynclitism. So for me, occiput anterior position, it was enough trouble in the second stage of labor than to, deal with this, classic definition. But looking at the literature and trying to understand, I found it very easy, and it's really easy to understand, and you will see in a moment. So asynclitism can be divided into 2 situations, depending, if you look at me, depending towards which shoulder the head is tilted, either the anterior shoulder or the posterior shoulder, okay? So if the head is tilted towards the posterior shoulder, it is called anterior asynclitism. Remember, posterior shoulder, anterior asynclitism. If the head is tilted towards the anterior shoulder, it is posterior asynclitism. The only drawing that I understood was this one, and I give credit to the author, was I think an author from India. So the head is tilted towards the posterior shoulder, okay? And it is called anterior asynclitism. So it's not a good thing when the head is tilted towards one of the shoulder at the beginning of the second stage of labor. So now how can we diagnose anterior asynclitism? Remember, head tilted to the posterior shoulder, okay? And so the sagittal suture will be closer to the posterior part of the pelvis, to the posterior shoulder. So Antonio Malvasi say you can use the squint sign, and they published 4 or 5 papers about the squint sign, which is basically to put the transducer above the symphysis, and then you see just one eye facing you, one eye, not 2 eyes, but one eye. It is a sign of anterior asynclitism. Now, Tullio Ghi does the same thing, and this paper was published in the American Journal recently in 2017, does the same thing by just moving the transducer below the symphysis. So you place the transducer below the symphysis. If the sagittal suture is very far back, you are probably dealing with a anterior asynclitism, basically head tilted towards the posterior shoulder. Okay, now let me show you a clip how the sagittal suture should look like when you move the transducer below the symphysis. Okay, let's start. And so this is the transducer that is on the perineum. Okay, you have the head descent, okay? And then look what I'm doing. I am just rotating the transducer by 90 degrees. And this is how you can see the sagittal suture, okay? Now the head is, the transducer is rotated, and I will stop here, okay? And if this suture is at equal distance between the anterior part and the posterior part, you are obviously not dealing with asynclitism. If this suture is very back to the back part here, it is an anterior asynclitism, posterior asynclitism. If the suture, anterior asynclitism, if the suture is very anterior here, then you are probably dealing with the posterior asynclitism. So now the posterior asynclitism, remember the shoulder tilted towards the head tilted towards the anterior shoulder. And the thing is, this is the situation we really want to diagnose, okay? Because in posterior asynclitism, the head is impacted against the symphysis. And I asked some obstetrician in my institution now at Sidra, I told them which of the two cannot be delivered. And many answered correctly. It is the posterior asynclitism, okay? Cannot be delivered unless you do special maneuver, and I will come to this in a moment. So this is how it is diagnosed, okay? So there is only one paper about posterior asynclitism. The head tilted to the anterior shoulder, okay? The sagittal suture very close to the symphysis. And Tulyugi, in a letter to the White Journal, to the Ultrasound and Obstetric to the Journal of Ultrasound and Obstetric and Gynecology, says you just have to take your transducer and you rotate it upwards. So if you see the sagittal suture, then you are probably dealing with a posterior asynclitism. Clip, because this is really, you know, the easiest way, okay? Turn the transducer transverse like this, okay? And then if you see the suture at the sagittal midline echo at equidistance from anterior posterior, you are probably dealing with a normal situation. So let's go now to the intervention for asynclitism. I looked a lot at the literature. The only thing I can find is this one. Stand with one foot on a stool when you are standing. So put one foot on the stool, it will cure the asynclitism. Or sit on a toilet with one foot on a stool and the other foot on the floor. Or pull on a towel during pushing and keep moving during the contraction. It's another one. And I like this one. Shake the mother buttock in the same speed you would shake a branch to make a ripe apple fall from the tree. So you can see these comments are coming, or intervention are coming from
Karim. Sorry, Karim, you're 3 minutes over.
I'm done. This is the conclusion. So what I would say is, be aware of the condition and don't try to deliver with instruments, one of these asynclitism, otherwise you will end up in trouble. Thank you for the opportunity to give the talk and for listening.
Thank you. We'll move straight on to Dr. Nomura from Brazil, Roseli Nomura, who's going to give us a 3-minute presentation on simulation-based learning activities. Thank you, Nomura.
Hello, are you hearing me?
Yes, we hear you.
I will share my presentation now. Yes, here. Yes. Yes. And this abstract is about comparison of two simulation-based learning activities in the acquisition of skills for students of undergraduate students of medicine. We know that we have few studies in the literature about the design of optimal simulation training in childbirth. And our objective was to compare two different simulator-based based learning activities for the second and third stages of birth attendance, and to verify which of the two methods offers better acquisition of expected skills by undergraduate medical students. Next, yeah. The methods, we performed this study between July and December 2019. The students participated as a part of their schedule, academic teaching, and all gave informed consent. We used this simulator, the Noelle. And before simulation, we performed a briefing session for 15 minutes. The group of 4 or 5 students were separated into two groups, Group A and Group B. Group A, all students observed the simulation of birth assistance properly performed by a professor. Then one of the students repeated the simulation, and then we performed the debriefing. In the Group B, one of the students performed the simulation directly without the professor demonstration. And then we performed the debriefing, and then another student repeated simulation. After each simulation, the debriefing session was recorded for later evaluation, and the teacher and the students can re-evaluate the scenario, and we can improve the development of clinical skills, respect, and learning process. 1 week later, students were subjected to practical evaluation in simulation context. This is the scenario. The parturients, 28-year-old, primigravida, and the student had to enter the delivery room and attend the childbirth. Every student performed the scenario individually, and the scenario lasted on average of 15 minutes. And the skills that we trained was second stage assistance, pushing, hands-on perineum protection, late cord clamping, skin-to-skin contact. And in the third stage, the active management of third period, oxytocin, controlled cord traction, placental rotation, placental revision, and perineal revision. The debriefing was, we applied an assessment scale, reviewing the videos. We used a 5-point Likert scale in 5 subscales, comments on 5 tasks. And the instrument for practical performance assessment was used to evaluate the tasks by each student 1 week later. Yeah. This is the results. 57 students participated in this study. We have no difference between the distribution, age, and in the final score at the evaluation. And when we look at specific points in the debriefing, the discussion and comments about the third period, we have more discussion in the Group B that performed the simulation directly. And when we look to the practical performance of these students, after 7 days, we found more adequate hands-on perineal protection and adequate technique for skin-to-skin contact in this Group B. And then we think that the key messages, the learning of skills in childbirth care is supported by the challenge of students act directly in the simulation. This is a challenge for them. And then with later discussion in the briefing, the students that participated in obstetric simulations better understand the physiology of parturition and the procedures. And we believe that the students can learn the skills to help during labor mainly with actors, then they can learn how to handle patients and in situations gently, respectfully, and professionally. Thank you.
Thank you very much, Dr. Spinner. So
Yes.
I think that brings us to the end of that. Thank you, Dr. Nomura. Most of the questions I can see have been answered. I think Karim is working through a few. There's one more for Daniel. When do you measure the uterine scar? At 36 or 37 weeks?
Thank you. I just saw this question. We do between, so certainly before 37 weeks, between 36 and 37 weeks is just about what you say. There is still the question if we need to decide to induce a patient because, for example, because she's going over the due date, so we will check again the scar, but between 36, 37 weeks would be the moment that we take a measurement, as I said, to make sure that there is no uterine dehiscence, so that the scar is intact, and we look at it if we can measure above 2 millimeters, which would be the optimal situation.
Okay, thank you very much. Are there any other questions or any other comments from either the speakers or otherwise? I don't think other people have got audio, have they, Fabio? Okay, then. Well, look, can I finish up by thanking all the speakers and especially the participants. It does seem a bit strange that we can't look at you or see any smiles or other facial expressions. But anyway, I hope you've enjoyed it and you've heard what we've had to say, and hopefully it'll help you with your work. Good luck and stay safe. Bye.
Thank you. Bye.
Thank you, Giancarlo and Roberto. Thank you all.
Thank you for the participation. Then we have to move now for PPH prevention, correct?
Yes.
Is Team Draycott already online that can start?
Giancarlo, I'm here. Thank you.
Thank you so much for being here. If you can start, we are perfectly on time.
Perfect. Look, absolutely delighted to be able to present today with some of my team. And it's going to be me and Cathy Winter talking about the management of PPH, particularly in these COVID times. Yeah, how should we manage and train for PPH? Cathy, who is the midwife lead for the Prompt Maternity Foundation. But first of all, I'd like to introduce Helen Van der Nelson, who's a registrar with us in the southwest of England and actually started and led the IMOC study. And she will present what is a wealth of new data for the prevention of PPH. It's been published in the last year or two. So Helen, if you'd like to start, we're really looking forward to hearing your talk.
So just check you can hear me.
Yeah.
Yep.
Sounding good. Lots of books behind you. Good.
Can you see my screen?
Yep.
Just check that's my first slide.
Yeah.
Yep. Great. So my name is Helen Van der Nelson. I'm a registrar in obstetrics and gynecology in the southwest of England, and I'm going to chat through PPH prevention and the personalisation of care, so how we might interpret some of the more recent evidence to help us personalise the care which we give to our women. So PPH remains a significant contributor to maternal mortality worldwide. We know it's the most common cause of direct maternal death and accounts for 27% of all maternal deaths. We know there is vast disparity between deaths in the developing and the developed world. Risk of dying of PPH in developing countries lies at 1 in 1,000 compared to 1 in 100,000 in the UK, for example. However, even in the UK, PPH is still the leading cause of maternal morbidity, and PPH rates are thought to be rising. As a global community, we face the ongoing challenge of meeting Millennium Development Goal number 5 and new Sustainable Development Goals. We know that, as with a lot of things in obstetrics, prevention is better than management or cure. And significant new data exists on PPH prevention. And it's important for us to consider this and think what this data means for our practice. So we've known for several decades that active management of the third stage of labour reduces risk of PPH compared with physiological management. And we are now seeing that the use and choice of uterotonics is key to this triad of intervention. I'm going to chat through some of the new data and recommendations, including 3 large recent trials and a network meta-analysis covering both vaginal births and caesarean section. So what's new in active management? Well, it seems everything has changed. In practice, it's been recognised that women often receive care which doesn't truly fit into the definition of either active management or physiological management. And so the individual components of active management have been scrutinised for us to understand what it is that actually works. So I'm going to look at all of these 3 parts of the triad of intervention individually. So looking first at timely cord clamping, as it's more commonly known now. So immediate clamping of the umbilical cord was commonplace in many countries not so long ago. And evidence now suggests that there is no increase in maternal PPH when cord clamping is delayed by 3 minutes. There are also significant benefits for the neonate, including a reduction in neonatal anemia, although this comes with an increase in rates of jaundice and the need for phototherapy. And we must consider that this isn't immediately available in all settings. There are also longer term benefits, including neurodevelopmental benefits. We have seen recently that delayed cord clamping compared with early cord clamping improves scores in fine motor and social domains at 4 years of age, especially in boys. Moving on to controlled cord traction. There is evidence that use of controlled cord traction may reduce the need for manual removal of placenta. But interestingly, it's now been found that omission of controlled cord traction has very little effect on the risk of severe hemorrhage. It's been concluded that the scaling up of hemorrhage prevention programs can safely focus on the use of oxytocin rather than necessarily making widespread programs for teaching and training controlled cord traction. People that can perform this are not present in all settings. I'm now going to run through some of the more recent evidence relating to prophylactic uterotonic drugs, including 3 large studies, Champion, IMOX and Labour trial, a network meta-analysis and some international recommendations. So looking first at the EXIT trial, this was a multi-centre randomised trial comparing 5-unit oxytocin bolus with a placebo infusion and 5-unit bolus with a 40-unit oxytocin infusion in 2,000 women undergoing elective caesarean section at 36 weeks or more gestation in Ireland. The main outcome was PPH more than 1,000 mils, and it found that there was no difference in major PPH rate between these 2 arms. Although interestingly, it did show that PPH rates increased in women delivered by more junior obstetricians, perhaps because we're slower when performing caesarean sections. The LOXI study compared carbetocin and oxytocin 5 units intravenously at caesarean section. This was a double-blind randomized control trial in a single centre, Southmead Hospital in Bristol, where Cathy, Tim and I work. It involved 377 women having emergency or elective caesareans, and it concluded that carbetocin reduced the need for additional uterotonic drugs when compared with oxytocin. There was no significant difference in the other outcomes, including PPH, transfusion, or a drop in haemoglobin level. A Cochrane systematic review of looking specifically at carbetocin in 2012 had a section of it looking at caesarean section, and this included 5 randomized control trials. And it concluded that carbetocin is more effective than oxytocin for prevention of PPH in women having a caesarean delivery. So that's all the caesarean section focused studies. Moving on to vaginal births, the Champion study was a very large randomized control trial looking at vaginal birth. So it compared carbetocin, 1 dose IM, or oxytocin, 10 units IM, for 29,000 women after vaginal birth. So that was across 23 sites in 10 countries. It was a non-inferiority comparison, and there were 2 primary outcomes. One was PPH more than 500 mils or the use of additional uterotonic drugs, and the second was PPH more than a litre. And it showed that for the first of those 2 primary outcomes, carbetocin was non-inferior to oxytocin, and in the second primary outcome, non-inferiority of carbetocin was not shown. It was concluded that low event rates for PPH more than 1,000 mils reduced the power of this comparison. The IMOX study, which looked again at vaginal birth, was a multi-centre randomised control trial taking place in England, and we were involved in that. That's a study that we've led on. It compared 3 different drugs, all intramuscularly given. So oxytocin, 10 units, sintimetrin, 1 dose, or carbetocin, 100 micrograms. There were 3 pairwise comparisons made, and the comparison between sintimetrin and carbetocin was a non-inferiority comparison. The other 2 comparisons were superiority comparisons. Our study included 5,929 women randomised, and our primary outcome was the use of additional uterotonic drugs. In terms of that primary outcome, we found that sintimetrin reduced the need for additional uterotonic drugs compared with both oxytocin or carbetocin. And in our study, non-inferiority of carbetocin to sintimetrin was not shown. In terms of the difference between carbetocin and oxytocin in that pairwise comparison, there was no significant difference. And in our secondary outcomes, which included weighed blood loss and blood transfusion, there was no difference. Although in terms of side effects, sintimetrin was significantly worse, and that was for outcomes including nausea, vomiting, headache, and abdominal pain. The LABOR trial was a randomised control trial comparing intravenous and intramuscular oxytocin 10 units after vaginal birth. And this seems to be a real keystone study for how we might personalise the care of our patients. It involved 1,075 women in Ireland, and it showed that outcomes were improved with IV rather than IM oxytocin. So there was a reduction in severe PPH, blood transfusion, and admission to high dependency units. A network meta-analysis, this was the first Cochrane network meta-analysis in obstetrics, was published in April 2018, and it focused on the use of uterotonic drugs to prevent PPH. The uterotonics evaluated were oxytocin, ergometrin, misoprostol, carbetocin, and combination drugs, including sintimetrin and misoprostol plus oxytocin. The analysis included all randomised controlled trials published up to October 2017 in the first instance. And so it didn't include the Champion study to start with, because that was published in June 2018, but then the updated version did include that study too. So the network meta-analysis looked at prevention of PPH after vaginal birth for outcomes including PPH more than 500 mils and PPH of more than a litre. It found that compared with oxytocin, the 3 best drugs for preventing PPH more than 500 mils were sintimetrin, so that's oxytocin ergometrin combination, carbetocin, and misoprostol oxytocin combination. In terms of PPH more than a litre, there was little or no benefit when compared with oxytocin of sintimetrin or misoprostol plus oxytocin. There was uncertain benefit or evidence relating to carbetocin or ergometrin compared with oxytocin, and outcomes were worse with misoprostol compared to oxytocin. Carbetocin had the most favourable side effect profile amongst these top 3 options, and the side effects compared with oxytocin were particularly vomiting, hypertension, and fever. So this isn't actually a uterotonic drug, but I think still important to mention. Tranexamic acid is really the talked about word at the moment. The TRAP study looked at tranexamic acid for prevention of PPH. So it compared 1 gram tranexamic acid versus placebo after oxytocin at vaginal birth. It included 3,891 vaginal births and was a double-blind randomized controlled trial. It showed improvement in provider-assessed PPH, but no difference in measured PPH up to 500 mils. and interestingly, no increase in thromboembolic side effects, which is something that we do often worry about. Moving on to some recommendations. So the World Health Organization most recently updated this guidance in 2018. So this is Utratonics for the prevention of postpartum hemorrhage. It recommends using a Utratonic for all births, and that oxytocin 10 units IV or IM should be used for all births, or carbetocin if its cost is comparable. Carbetocin has the added benefit of being thermostable, unlike oxytocin, and this is particularly important in developing countries. It does stipulate that carbetocin is for PPH prevention only and not for treatment of a PPH if it were to happen. There was an international consensus statement for caesarean section published in 2019, and this was published because there were no other guidelines or recommendations dealing specifically with Utratonic management at caesarean section. It suggests that a universal dose for all cases of caesarean is not appropriate, and we should be differentiating elective sections from intrapartum caesarean sections, and that potentially high-risk elective patients should be given an intrapartum dosing. It also talks about the adverse effects of oxytocin boluses, so large boluses or large overall doses of oxytocin administered, and suggests that we should be giving a slow, smaller bolus plus an infusion for all patients. And interestingly, the bolus sizes recommended by this consensus statement are smaller than those recommended in other guidelines. So for elective caesareans, for example, it recommends a 1-unit oxytocin bolus, or for an intrapartum caesarean section, a 3-unit oxytocin bolus. It suggested that carbetocin may become the preferred first-line drug, and that in settings where infusions are not readily available, we should consider an IM dose in place of an infusion for longer lasting effects. So carbetocin is more expensive than oxytocin at cost price. So an economic impact analysis for caesarean sections was performed from an NHS perspective. This modelled 1,500 caesareans over a 12-month period. And for this model, efficacy data was taken from the Cochrane meta-analysis, and costs were taken from a combination of NHS reference costs and the British National Formulary. Resource use estimates were also created from hospital audit data, which told us things like the mean number of units transfused for PPHs of a certain volume, and expert opinion was used to gauge the number of professionals that might attend a PPH of any given volume. So outcomes in this study were PPH rates and overall cost, and it showed that carbetocin use resulted in 30 fewer PPH events over this 12-month modelled period, at a cost saving of £27,000, averaging out at £18.31 per caesarean section. So this is quite a lot of new data that's emerging, and we must consider how we can use it to personalise the care that we provide. PPH risk prediction tools might certainly help us predict which women might be most likely to have a bleed, and we should be tailoring the prevention strategies for the patient in front of us. So really considering, caesarean versus vaginal birth, which drug should we employ, elective versus intrapartum caesareans, and perhaps the dosing regime, and generally high risk and low risk patients. Vaginal births, this might mean an intravenous dose versus an intramuscular dose. I know in a lot of countries, intravenous dosing is commonplace because labouring women have cannulas, but in the UK, that's not routinely the case. So in conclusion, there does seem to be a new type of active management of the third stage of labour. We know that there are significant benefits and no downsides in terms of increasing PPH risk of delaying cord clamping at least 30 seconds or more. Controlled cord traction is probably not useful, and we know that Utratonics are absolutely paramount. We must consider risks versus benefits and the cost effectiveness of our choices. We've learnt that the use of an oxytocin bolus plus an infusion doesn't reduce PPH rate, that carbetocin is more effective than oxytocin at caesarean section. The network meta-analysis demonstrated there are 3 drugs that are more effective than oxytocin. IV oxytocin is better than intramuscular oxytocin. Prophylactic tranexamic acid is not of benefit. And carbetocin is recommended at vaginal birth if the costs are comparable, and there are modelled outcomes which suggests that carbetocin is cost effective. Thank you very much.
Great, Helen, that's absolutely great. And I think a really excellent summary of all of the new data in PPH prevention, which are a lot, let's face the facts, and including your own trial. So thanks very much for that. Cathy, I think we're going to share our talk. You're going to give the first part of the talk. So if I start the slides, then we can...
You can be my assistant.
And yeah, I can be your assistant.
You can be my glamorous assistant too.
You're not very glamorous assistant. So yeah, looking forward to presenting. Yeah, I think some of the new data about the immediate management of PPH, and particularly how COVID, the context we're working in, has slightly changed in COVID times. Thanks very much. Cathy, I'll go on to the first slide if that's okay.
That would be lovely, thank you. Yeah, I just want to say how odd it seems that we're doing this talk and we don't know who we're talking to. It's quite odd, but hopefully everybody's still there and enjoyed Helen's talk. So we're going to carry on now. Just a little bit of an introduction of what we're going to cover. Just the immediate management, caring for a woman who's having a postpartum hemorrhage. A little bit about using algorithms and emergency boxes and how, you know, our little motto of making the right way the easy way, and then touching on the additional care that may be needed in a woman that has confirmed COVID-19. Clearly, we're referring to national guidance, obviously guidance on the use of PPE, talking about systems that you might have in place that might make it easier to manage in these difficult times where women may have COVID. And then also the communication difficulties that may come alongside the extra use of PPE, etc. And at the end, we've got a couple of slides on extra sources of information. Are you able to turn on, Tim? Next slide. So if we're just sort of going to the basics here of causes of postpartum hemorrhage, 4 main causes, we would say tone, as in our atonic uterus, tissue, as in retained placenta or membranes or blood clots, all within the uterine cavity, preventing the uterus from contracting, trauma, and that could be sort of vaginal tears or cervical lacerations, and coagulation defects. The commonest cause we all know is an atonic uterus, and often you have that atonic uterus secondary to your retained tissue, whether that be placenta and membranes or blood clots that are sitting in the uterine cavity. Coagulation defects as a primary source are probably a rarer cause of PPH. They tend to be the DIC that develops secondary to the depletion of clotting factors as the hemorrhage gets worse, essentially. And generally there's often more than one cause of that bleeding. Next slide. So thinking of things that might help us to manage emergencies, we talk about PPH emergency box, or a lot of units we know have trolleys now. Clearly, whatever system you have, and we always say in our training that, you know, it's very important that locally staff are familiar with whatever system you have. And again, the box or the trolley is a way of making it easy for us to do the right things, because generally everything that's in the box or the trolley needs to be used in that immediate care. And very important that you have an algorithm. The algorithm being something that you'll train your staff in your local training days, how to use the algorithm and how to do a step-by-step approach to managing the emergency. Just to say that your emergency box or trolley is only as good as your stocking system. And so again, as part of the training, you need to make sure that all your staff know how to stock it, where it's kept, because there's nothing more unhelpful than grabbing your box or trolley, and actually the resuscitation fluids aren't in there, so that's not helping you at all. So think of your stocking systems as well. Okay, next slide. Okay, so there's an example of an algorithm, step-by-step approach to managing the PPH. And PPH is one of those emergencies that actually is quite complex in that a lot of things happen all at once. So you do need quite a few hands there to help, and definitely somebody that's calling out the steps that you need to do. Whatever the system is in your units, we would recommend that you make sure everybody's familiar with the algorithm, and as I say, that it's kept with your emergency equipment. Next slide. Okay, so just touching on COVID-19 now, I guess key things there are that certainly in the UK we have national guidance provided by the RCOG and the RCM. They've joined together to produce a document that's continually updated. So I would recommend that if you want any information on caring for pregnant women with COVID, go to the website. You'll see straight away that there is the coronavirus infection in pregnancy document, and if you go to the website, you'll know you're on the most up-to-date version. You can see that the anaesthetists association and the intensivists associations have joined together to provide another national document which is looking after women that perhaps are critically ill with COVID. So again, look on these websites, get your most up-to-date information. Next slide, Tim. So thinking of one real key thing that probably has changed significantly since we've obviously had COVID with us is the use of PPE, personal protective equipment. And again, this was something that certainly at the start of the pandemic back in March, certainly in the UK, our units, our staff felt quite alien to this, and it was quite a worry how specific ways that and equipment that you use. And as we know, again, equipment in units is different, and often you can train in one set of equipment and then the next batch that comes in is a different set of equipment. So again, really can't emphasize enough that locally you need to make sure your staff are familiar with the equipment. Now, the Public Health England website has very useful videos to help with staff to be familiar with donning and doffing, and they also have some infographics and things that you can print off. Can you just go to the next slide, Tim? And you can see that there's quite a few useful doffing and donning guides. The intention is you print them off, laminate them and put them with all of your doffing and donning trolleys so that staff can see step by step the process that they need to do. And again, very, very useful for practicing. So again, we would recommend, if you can, make sure that there's simulated circumstances where you can maybe get staff practicing and putting the equipment on. Next slide. Okay, so other systems that you might think about, we've already mentioned the emergency box and the emergency trolley. Of course, you've got probably quite a bit of equipment in there, more than you'd need to manage one PPH or whatever the specific emergency is. So one idea is to have a grab bag. We call emergency grab bags. You can see we've got a selection of them on our shelf in our unit. And the idea being that you've got one of each item that you need for the emergency, single use, and the good thing is that you're not wasting any resources, and everything in there is used for that one emergency, and then there's nothing that you're needing to take out again, which you couldn't take out obviously if it was a COVID positive woman. Paper algorithm, really important to have in your pack there so that somebody is reading the algorithm as well. So again, useful to think of these systems. Next slide, Tim. Okay, so what we've got now is just a short video. It's about 4 minutes long. We made it at the start of the pandemic, in fact. Probably things have changed slightly since the start, to be honest, with PPE. But it's just showing, it is showing a PPH, but it's actually showing the systems that you need to think about to manage the emergency, given that you needing to minimise the number of staff that are going in the room, and of course they have got to be fully protected. So we'll just play the video.
Even for teams very skilled at dealing with obstetric emergencies, managing them in women with confirmed or suspected COVID-19 presents extra challenges. These include considering methods of calling for help, ensuring no one attends the woman without appropriate PPE, making sure the most skilled team members get to the woman first, using teamwork to speed up the donning of PPE, grab bags to get the right treatment started early, communication issues due to masks and visors, which may be helped through the use of treatment algorithms, and acknowledging that this may be a stressful time for the woman and helping alleviate her fears, and also planning the logistics of transfers. Here, a woman with suspected COVID-19 has just given birth, and the midwife discovers that a significant postpartum hemorrhage has occurred. The midwife ensures that mother and baby is safe and needs to call for help. Getting the right help in a timely fashion needs to be done in the context of infection control. Emergency buzzers, 222 calls, phone calls, walkie-talkies and intercoms have all been successfully used, but all have their pros and cons. So see what works on your unit, refine the system through testing, and then train your teams in its use. In this situation, the midwife pulls the emergency buzzer. The team responding have been trained and know not to enter the room without PPE. The first responder ascertains the nature of the emergency, in this case, postpartum hemorrhage, and she confirms this with closed-loop communication. She can now explain the nature of the emergency to the incoming team. This allows the team to don the appropriate PPE for this emergency. It also allows the team to know which member should be prioritised to don PPE and enter the room first. The priority team member depends on the emergency. As this is an obstetric emergency, the most senior obstetrician has assumed leadership. She allocates tasks to the rest of the team, including retrieval of emergency equipment and the donning priority. Having someone designated to help the rest of the team don PPE first means the senior responders can start definitive management more quickly. Simulations done at Leeds University hospitals have reduced response times by 1 to 2 minutes by doing this. Single-use emergency grab bags can overcome the issues of wasting emergency equipment, as would happen if emergency boxes or emergency trolleys were brought into a room contaminated with coronavirus. The grab bags should contain the leanest equipment needed, plus a treatment algorithm, and be replaced after each use. PPE makes communication challenging. Teams should concentrate on being clear and succinct. S-bar handover is an effective way of doing this. Closed-loop communication allows team members to know that instructions have been heard and understood, thereby closing the communication loop. Treatment algorithms are powerful tools to ensure prompt treatment, clear communication, and improve situational awareness. Even a junior team member can work through the algorithm, ensuring the team completes all the management steps. Meows charts can also help the team track the woman's severity of illness and her response to their treatment. Obstetric emergencies can be daunting for the woman and her partner. This can be exacerbated by teams wearing PPE. Keeping calm and keeping the woman and her partner informed can help alleviate this. Transfers, such as to theatre, are more complex owing to infection control considerations. Units should carefully consider the logistics so that when a transfer is needed, the woman and all the necessary teams and equipment can converge on the destination smoothly. Use multi-professional walkthroughs and simulations to refine and test the system, and then train your staff in its use. Correct doffing is vital for infection control. At the end of the patient episode, before leaving the room, theatre, doff gloves, gown, apron and visor. For performing hand hygiene, and then exiting to doff the face mask, before washing your hands with soap and water. For easily digestible, up-to-date information on managing confirmed or suspected COVID-19 women, visit our website or email us for our latest COVID-19 newsletter.
Great. And if you visit our website, you can see that video without it being jerky as well. I don't know, I was watching it and maybe it wasn't for all of you, but it looked a bit stilted. But certainly visit the website. There's several different newsletters that may be helpful if in our second wave of COVID, as we seem to be approaching. Just recapping on that video there, and the different steps, I guess you would say, about managing this emergency in a COVID positive woman. Obviously ascertain the emergency before entering. I mean, our normal response when a call bell goes, emergency bells, is everybody rushes into the room. Obviously you need to have somebody to stop people going in the room, because you need to be donning your PPE first. So somebody allocated, stop them going in. They know what the emergency is, tell the team the emergency, and then the team can decide who is the priority to go in the room. Use your team to help you don, so sort of have a buddy system where somebody's helping each other put on their PPE. Allocate a clean runner outside to bring the emergency grab bag or whatever is required. Make sure all the staff know that at the end of the emergency they need to doff all of their PPE before they leave the room, except their mask, and the mask is doffed outside the room, and hand washing at every stage. And then really important that the team debrief, just as we would with any emergency. This is additional debrief to see whether there were any things in the system that maybe could improve or streamline, so that if it occurs again, the team can improve and be a bit more, be quicker with their management, I guess. Next slide, Tim. Okay, so just going back to managing our PPH. I think Tim and Helen have mentioned about risk assessment and early recognition if you have a woman with a PPH, and clearly risk assessing prior to labour and in labour those women that might be at higher risk, and being prepared so that you're already on top of things should it occur. Certainly thinking of our COVID women as well, they may well be on VTE prophylaxis if they're severely affected. And of course, if that's the case, then we need to anticipate and stop the VTE prophylaxis at least 12 hours prior to labour. So again, thinking ahead there. Thinking of our early recognition, it can be difficult to estimate the blood loss, and sometimes you can't see all the blood loss. It may be collecting in the uterus, and actually the blood loss outside isn't that much. But look at mother's condition, look at her vital signs, chart her observations, and look at the Muse chart and see whether there's any amber or red flags that make you think actually this woman's condition is deteriorating. And then act on those signs and symptoms. And of course, continually monitor the fundal height, feeling the uterus, whether it's firm and whether it's getting higher, which may indicate there's more blood loss inside. Next slide, please. Okay, and then thinking about tools that might help you, with the risk assessment, and then managing the PPH. If you look at these tools, this is actually a 4-stage chart, PPH chart, which is based on the OBS Cymru PPH 4-stage checklist that they have. And if you go on the OBS Cymru website, and we've put the link at the end as well, you'll find that they have the OBS Cymru 4-stage chart there. And the key thing with the 4-stage chart is that you have risk assessment as your first element. Then your second element is helping you to do early identification of the PPH. So what stage are we at? Are we at 500 mils? Are we more than 500 mils? It also incorporates multi-professional team working and requires you to write down all the different team members that are there, and prompts you to call them. And then also there's your point of care testing, which gives you a rapid sort of coagulation status, so that you can guide any blood product that you might require. Next slide, if that's okay. So thinking of our major PPH and the actions that we do initially, we're going to call for help. We're going to declare that emergency and state when people arrive what that emergency is. And as I say, locally, you need to make sure everybody knows how you call for help. If it's a COVID lady, don't have everybody rushing in. Make sure that somebody is shouting at the door what the problem is. And then if it's a major hemorrhage, you may initiate the major obstetric hemorrhage protocol as well. You want the key people coming, and again, certainly with COVID, you're going to gown up those vital people, your senior midwife, your experienced obstetrician, an anaesthetist, but keep your team to a minimum if it is a COVID positive lady, because you want the minimum of staff exposed. And then if it's depending on how bad the hemorrhage is, you'll want the consultant obstetrician, the consultant anaesthetist, and maybe you're alerting the hematologist as well if you're going to need blood products. And as I say, make sure that you are familiar with the PPE trust policies, because they are varied depending on each trust. Okay, could you go to the next slide, Tim? Okay, and so thinking of our first line of our algorithm and the initial management, as we said, you're going to call for help, you're going to lie the woman flat, administer high flow oxygen, and then you're going to secure IV access so that you can do rapid fluid replacement. All the time you're assessing the blood loss, and we'll talk about the importance of measured blood loss, because then you can titrate your fluid replacement against that blood loss. And of course, you're assessing the cause. Next slide. So thinking of fluid resuscitation, as we said, the aim is to restore the circulating volume. I guess what we would say is that women die from hypovolemia. So, and if you look at the Embrace report, which is one of the UK sort of reporting systems, they identify that many instances where there's been under replacement of fluid, and women perhaps have not been managed well or have even died because they haven't noticed the amount of blood loss. So that brings us on to the importance of weighing your blood loss, and not only weighing it individually, but giving a cumulative measurement so that staff are aware how much cumulative blood loss there is as well. Can you show the next slide, Tim? This slide is just showing how bad we are, in fact, at assessing blood loss. If you look at the black line and the black dots, that's actually the actual measurement. That's the actual measured blood loss. And then you can see lots of coloured arrows all around it, where you have different members of staff that have estimated different volumes of blood loss. And you can see there's a wide variety of measurements, estimations, and not many of them around the actual black dots. So just a great illustration that we're not great at estimating it. So definitely important to weigh your blood loss accurately. Next slide, Tim. Thank you. And hand in hand with weighing the blood loss is obviously having an idea of the dry weights. So this is from our unit, and this is just showing the different weights of all of the different drapes, swabs, etc. that we might be using, so that you can deduct the dry weight, giving you an even more accurate weighed blood loss, as we'd say. Next slide. And then just again on the effects of maternal weight and blood loss. So again, this is one of the things highlighted in the Embrace report, is obviously you titrate your fluid replacement based on the amount of blood loss, but take into account the woman's stature. So for instance, a woman of 80 kilos who loses 1500 mils has lost about 18% of her circulating blood volume, whilst in a woman who weighs 50 kilos, so quite a bit smaller, this will be about 30% of her blood volume. So you can see this woman is going to be more hypovolemic, and definitely not going as well as your bigger lady. So do consider the size of the woman as well. Okay, you'll be glad to know, Tim, you haven't got to carry on waiting for me to ask you to turn now, because it's your turn.
Great. Thank you, Cathy. And I think that's really illustrated some of the problems we have at the moment with COVID and how we manage emergencies. Now, I don't think it's a surprise to anyone that stopping the bleeding will require an additional uterotonic, tranexamic acid, really important to give that early. And certainly we would give it after 500 mils plus of bleeding have an early threshold for giving it. Then consider oxytocin as an infusion, put a catheter in, and then there are other drugs to give, as you know, but clearly the underlying cause of the bleeding is what needs to be managed. So just quickly to run through all the drugs, which I'm sure you all know, Sintimetrin, all of these drugs are used, many for prevention as well as management, and apart from carbetocin, which is only for prevention. Sintimetrin and ergometrin are contraindicated clearly with hypertension, and syntosonon or syntosonon infusion are very commonly used as the first step in the management of an atonic PPH. Carbaprost and misoprostol are prostaglandin-derived drugs and can be used, after the first choice of uterotonics. And in fact, I think one of the things we've got to think about if we start using carbetocin more often is, should we use prostaglandin-based drugs earlier in the treatment ladder of PPH? And that's something I think we're going to have to think about as a profession. Tranexamic acid, I think it's absolutely clear that tranexamic acid is, when given intravenously, if you look at the woman study, reduces mortality irrespective of the mode of birth. It does not increase the thromboembolic events, which is very similar to the data that Helen presented for the TRAP study. And so I think what's absolutely clear is it doesn't seem to cause too many problems. It definitely has benefits, and therefore it should be given as early as possible, because after 3 hours, if you miss that 3-hour treatment window, then there is much less effect. However, at the same time, tranexamic acid may help with bleeding, but it doesn't help with uterine contraction, so don't forget oxytocin in that situation. Continuous assessment, I think it's really important, and something that's often missed out is that as the bleeding continues, it is essential that we continue to monitor the observations, particularly the measured blood loss, as well as the observation, blood pressure, pulse, etc. I think sometimes, particularly when someone's transferred to theatre for an EUA, and particularly around the time of considering blood products and invasive monitoring in particular, then one useful element I always think is take 20 seconds to plan the next 20 minutes. So just stop for 20 seconds, just reiterate what's happened management-wise, and then plan the next 20 minutes. So, here's a woman, has arrived, placenta in situ, she's got a spine in, actually her blood pressure is dropping, her pulse is increasing, we've given oxytocin, let's get on, maybe do a ROTEM, and we'll talk about point of care testing. So take 20 seconds to plan the next 20 minutes. This is a Muse chart that I'm sure many of you use. We use them routinely in all births, both for antenatal, intrapartum and postnatal observations. And for us, one of the things we saw in the UK was people don't add these scores up very well. So we just do 1 red, 2 ambers, call for help, and someone will come and review the woman. I think one of the big changes, certainly in my lifetime as a consultant, has been how careful now we are with respiratory rate. And you can see that's almost at the top of the chart as a really good indicator of deterioration in otherwise fit, healthy women. Point of care testing. Now, point of care testing is a very developed world issue. I think much less available in low middle income countries, but I think it's really, really useful. And certainly ROTEM has revolutionized how we manage PPH here in the UK. Now, HemoQ is a very rapid hemoglobin estimation. However, it's just a guide. And I think there are two issues with HemaQ. One is that it's a guide, it's not definitive, so you still have to send off the bloods. Secondly, before you fluid resuscitated someone, the hemoglobin can be artificially okay. Because as one of my anaesthetist colleagues points out, if you pour out half a glass of Coca-Cola onto the floor, you now have half a glass of Coca-Cola, but it's the same strength, it's the same concentration. So just don't be artificially reassured when the hemoglobin's apparently normal. Definitely arterial and venous samples, particularly for lactate, is now standard care and can be very easily accessed. Now, ROTEM, we have in our anaesthetic rooms. I will say, a skeptic. However, what is absolutely clear is that ROTEM gives you a very quick analysis of the clotting, and it helps you tailor the medication required. So it will tell you if you need platelets, if you need FFP, or if you need fibrinogen. So you don't give everyone everything. You look at the ROTEM, and working with your anaesthetist and the hematology lab, you can very much better target what is required. And that has been shown to be not only cost effective, but reduces the risk of abnormal filling and pulmonary edema. Intraoperative cell salvage, again, I think anyone who's used it, particularly in these days of placenta accretors, it has revolutionized how we work. And in particular, women are less acidotic and less cold when we use cell salvage compared to major transfusion. If you look at the Salvo study, a big multi-center study here in the UK, about 1 in every 100 mothers given cell salvage avoided a donor blood transfusion. But look at the data, it was as effective out of hours for people doing difficult sections out of hours, often by junior members of our team, as it was for high risk women. So if we're going to use it, it's probably as useful 24 hours a day than it is just trying to fit high risk women. So a couple of things, definitely treat the cause early and transfer to theatre. It's much easier, I think, to manage women in theatre. Think about uterine massage, catheterize, give uterotonics, empty the uterus, repair any tears, and clearly treat the coagulopathy. As I said, correction of coagulation defects, check the clotting, but definitely have a think about ROTEM. And you can see, this is what I was talking about before, you can use ROTEM guided management, and this is derived from the obs cymru work again, but there's a significant reduction in blood products and a significant reduction in ARDS and transfusion overload, as well as a reduction in cost. Now, again, this is a very simple system that the ROTEM will tell you what to give. So even us as obstetricians get a very helpful steer on how we should manage these women. Teamwork in management PPH is absolutely essential, as it is for many emergencies in our world. And if you look at Embrace, they identified a number of issues, particularly a lack of situational awareness, managing major hemorrhage, including people not communicating how much blood was lost. So there's certainly at least one death where there are 4 or 5 liters of blood loss on the floor, but the rest of the team were artificially reassured by a normal hemoglobin. The woman got 3 units of crystalloid, no other blood products at all, and very sadly died. Hemorrhage volume and measurement, as Cathy has pointed out, has really, again, made a big difference. There were significant failures to step back and take a broader view. Sometimes you get so fixated on what's going on in front of you, you can't kind of see what else is happening. And I think that's where this 20 seconds for 20 minutes planning really comes in very nicely. Think about tailoring treatment according to the diagnosis, yeah, and don't just keep giving oxytocics. That's the big mistake, is people give oxytocic after oxytocic, but actually there's a bigger issue and it needs to be dealt with. So take-home messages. Risk assess women to identify those at most risk of PPH. Now, after listening to Helen's talk, also give the best PPH prevention we can. I think that'd be the ideal thing. However, if someone is having a PPH, recognize it early. Think about weighed blood loss or measured blood loss, certainly. Consider the size of the woman volume of blood lost when initiating fluid replacement. Smaller women are affected more by the same blood volume lost. Early involvement of senior staff, effective treatment. I think effective treatment of the cause of the PPH is absolutely essential. Now, I'm not going to go into the detail of, hysterectomy, etc., but that needs to be taken into account, and those are clearly very senior decisions. So, also just bear in mind the COVID-specific measures. Now, Cathy is the midwifery lead for the prompt team, and we have actually just produced a set of resources that people can use for remote training. Face-to-face training is very difficult in the UK at the moment because of the problems of COVID. And if anyone wants to download it, it's completely free. It is a real wealth of slides, videos, and data you can use for training in your own setup. And if you just go onto the website, you can fill in a registration form and very quickly download it. So thank you very much for that. Let me stop sharing. I think we've got a few minutes left, 7 minutes in fact. Let me have a quick look at the questions. I've got a question here. A question maybe for Helen. If cost is not an issue, can carbetocin be the drug of first choice?
I think one thing to remember is that it's only licensed for use after cesarean section.
In the UK, in many countries, it's licensed for vaginal birth too.
Okay. So potentially, yes.
Yeah, so I'd agree. I mean, there's Helen, listening to your talk, there certainly seems to be benefits at cesarean section, at the very least. What the benefits are at vaginal birth, you mentioned thermostable, maybe Helen might be a benefit?
Yes, so definitely in developing countries where the supply chain and cold storage is an issue, there have been studies that have shown that of the oxytocin use used in some parts of Africa, only about 90%, of all the oxytocin in the samples, they were only about 10% effective because probably cold chain issues, storage issues. So in those situations, if there was a thermostable alternative, that would cut out that problem. And I think,
yeah, I mean, that's right. I always wonder whether not community midwives also might be useful doing home births, etc., etc.
And if you ask women, given the side effects of symptometrin and ergometrin, you haven't got the worry as well about the hypertension. If women are hypertensive, then clearly carbetocin can be given, and that seemed like that would be a safer option.
Now, Cathy, there's a fan of yours on the questions. Thank you, Cathy, for a great talk. Is it possible to share the content of the grab bags and the algorithms, please?
Well, in fact, if you download the tools, that's all included, in fact. So if you went onto our website, as Tim said, one of the first banners that comes up is the e-learning course that you can download, and you just have to fill in, there's a link straight away to an application form. So if you fill that form out, they'll give you a password to download it. And if you go to the postpartum hemorrhage section, you'll find that there is the algorithm, and also it shows you the grab bag. So that's probably the best way to do it, maybe. And obviously it's got other information about other emergencies as well.
Yeah, and more flattery from Nick Peridou, Helen and Cathy. One of the best lectures of PPH I've seen. Well done. But really concerned also about the measurement of blood loss, and says Cathy that, you know, why are we fixating on 500 mils? Yeah, maybe all blood loss might be important.
Absolutely, yeah, and in fact, you know, nobody can ever quite find out where 500 mils comes from. In fact, you know, in healthy women, 500 mils is probably quite a normal amount of blood loss, and doesn't render women, you know, some too much problem. But absolutely, and I think the one way to introduce measured blood loss is to make it that you do it all the time. I mean, we're very used to measuring blood loss in theatre and weighing the swabs in theatres, but certainly for us, we're doing it for the studies anyway. But the easiest way to introduce it is to say that we're doing this with all births, and then it becomes a routine thing to do, essentially, so that staff are using the same systems for all births, essentially.
And a last question, I think we've just got 2 or 3 minutes left. Any reason why 1.5 litres is the definition of massive obstetric hemorrhage? I think Avidia Nejad, that's a great question. And what is clear to us at the moment is that in our service, when we looked at this using measured blood loss, there was a change in care requirements after 1500 mils. So after 1500 mils blood loss, you're much more likely to, this is measured, not estimated, you're much more likely to require transfusion, a longer time on the labour ward, a longer time in hospital, everything else. So for us, there was a kind of clear threshold for 1500, people less than 1500 mils measured loss often went home at the same time as people without PPH. More than 1500 mils, you're much more likely to require additional care, which is why we use that in our unit. I've got one final question, Andrea Espinel. We don't use carbetocin in vaginal birth. Do you use carbetocin the same way as oxytocin? Do you give it when the shoulder's out? Helen, in IMOX, when did we give it again?
So for the IMOX study, we wanted to ensure that there was, because it's a randomized control trial, a trial of an interventional medicinal product, we didn't want to have any risk to babies. It was something unknown, something unlicensed. So we ensured that it was only ever given after the cord was clamped, which is not routine practice, not in the definition of active management of the third stage, although as we saw, there's no difference in PPH rate if you deliver the placenta, if you give the drug before or after the placenta is delivered, or when the cord is clamped. So we felt that was not detrimental. But yeah, for our study, the IMOX study, it was after the cord was clamped, whenever that was wanted by the woman. If she wanted deferred cord clamping, we went with that.
Perfect. So that takes us absolutely perfectly, seamlessly, exactly to 4 o'clock, Helen. Thank you very much. Absolutely perfect. So I'd like to say thank you to everyone, and thank you to Helen, fantastic. Thank you, Cathy, both of whom impressed the audience, I can see from the questions.
There's only 5 people listening. But...
no.
3 faces looking.
There's over 90 at one point. So look, thank you very much, and please have a look at the website.
I'm very thankful, fantastic seminar run by you and Cathy and Helen, so much thankful, especially in a day like this. Today is 10/10/2020. I don't know if you remark this.
Exactly.
Magic time.
10/20.
We are very thankful, and of course we invite me and Roberto, everybody, to the last Congress webinars next Saturday. But we are very happy that there was a very good attendance today as well, and thank you again for taking the time for participating, give us so very nice and important clinical inputs. Okay, thank you.
Thank you very much.
Thank you.
Thank you, Giancarlo. Thank you, Roberto, for inviting us.